So dear student, now we will talk about the characteristic physiological actions of adrenergic receptors. In previous videos, we talked about that how the adrenergic receptors alpha 1, alpha 2 receptors, beta 1, beta 2 and beta 3 receptors, how these receptors are logically distributed on our body tissues. Is that right? That is what we discussed in last video. Now we will be talking about that if there is some drug which only stimulate alpha 1 receptor, what will be the physiological changes in our body? Or there is another drug which specifically stimulates suppose only alpha 2 or only beta 1 receptor, or some drug is specifically stimulating only beta 2 receptor, what will be the typical changes in our biological system? So let's start about the characteristics, physiological changes in our body when a specific group of adrenergic receptor is stimulated, right? So we start with this characteristic physiological actions, physiological and of course pharmacological. Because physiological action when it is endogenous epinephrine and norepinephrine, but if you are giving some drugs, right, which are sympathomimetic drugs, the same actions will be said to be pharmacological actions. So characteristics, physiological and pharmacological actions, right, by the stimulation of, right, physiological and pharmacological action by stimulation of specific adrenergic receptors, right? Suppose if we have a drug which can stimulate alpha 1 receptors, what will be the changes? Alpha 1 adrenergic receptor. After this, then we will talk about that if there is another drug which specifically stimulate alpha 2 adrenergic receptors, then what are the changes in the body? And then we will be talking about that if we come across one more drug which can specifically stimulate beta 1 adrenergic receptors, right, what will be the changes in our biological system? And in the end we will talk about if we have some other drug which can stimulate specifically beta 2 adrenergic receptors, what are the changes in our biological system, right? Let's start with the alpha 1 receptors. Already we have discussed that alpha 1 adrenergic receptors are basically stimulatory receptors, right? When alpha 1 receptors are stimulated on any tissue, usually that tissue's activity is increased, right? Now characteristically, alpha 1 receptors are present, number 1, on the vascular smooth muscle, right? Number 1, there are many sites where alpha 1 adrenergic receptors are present. One is vascular smooth muscles, right? And when alpha 1 receptors stimulate the vascular smooth muscle, let's suppose this is a smooth muscle on a blood vessel, right? And this is alpha 1 adrenergic receptor. And when sympathomimetic agent stimulate alpha 1 adrenergic receptors on the vascular smooth muscles are stimulated. And when vascular smooth muscles are stimulated, it produces vasoconstriction. So primarily alpha 1 actions, alpha 1 stimulation on the vascular smooth muscle leads to vasoconstriction. But this alpha 1 mediated vasoconstriction on vascular smooth muscle will change the cardiovascular parameters. How? Let's talk about that. Let's suppose here is your beautiful left heart, right? And from the left heart, this is aorta and major vessels. And let's suppose from here, arteries are coming out and arteries are going down into, arterioles, right? I will just draw the cardiovascular system and we'll talk about that alpha 1 stimulation, how it changes different parameters of cardiovascular system. So this is arterial tree coming to the, yes, capillary network coming to venules, right, and then going to, yes, veins. And this venous drainage is of course going to which heart? Right heart or left heart? Yes, right heart. And from the right heart, you know, blood is pumped to the lungs, and from there, right, it will eventually come to the, yes, blood will get oxygenated and come to the left heart. Now, let's see that when alpha-1 stimulation occurs, alpha-1 adrenergic stimulation occurs, how the cardiovascular parameters are directly altered. As you know that arterioles, right, our arterioles have lot of smooth muscles, right, and these smooth muscles on arterioles, they are having adrenergic receptors. Let's suppose this smooth muscle, right, I bring it out, this is having alpha-1 adrenergic receptors. Now when alpha-1 agonist will stimulate it, these smooth muscles will be stimulated and constricting. When these smooth muscles will constrict, what will be the result? That these vessels will become narrow and blood flow from the arterial side moving to the capillaries and venous system will find more resistance. Again, when there is arterioconstriction and arterioles constrict, right, then when blood moves from arterial tree to the capillary side, it is facing more resistance. So it means when alpha-1 stimulation is there, many arterioles in the body, especially the arterioles in subplanchnic circulation, which is gastrointestinal circulation, arterioles in the cutaneous circulation, and arterioles in the renal circulation, all these arterioles will constrict and total peripheral resistance will be increased. The resistance offered by the arteriole for movement of the blood from arterial side towards the venous side will be increased. So what will be the result? Right, result will be increased total peripheral resistance on alpha-1 adrenergic receptor stimulation, right. So we can say arterioconstriction, that will translate into, yes, increase total peripheral resistance. Now, when total peripheral resistance will increase, then as blood will have more difficulty to move from arterial side to the venous side, so amount of blood in the arterial side will be slightly increased and pressure on the arterial side will be also increased. And actually, you know, blood pressure, you know, arterial blood pressure, systemic arterial blood pressure is having two parameters. Systemic arterial blood pressure is equal to, yes, systolic blood pressure by diastolic blood pressure. Now, you must be knowing that systolic blood pressure is the pressure in the major systemic arteries when heart is contracting, when left ventricle is contracting, and diastolic blood pressure is the pressure maintained in the major arterial, systemic arterial tree when heart is relaxing. Let me make a very simple diagram to explain this phenomenon. Let's suppose this is your left heart and this is arterial tree, and here are, suppose, your arterioles, right. Now listen, these are the arteriolar smooth muscles and which are very, very sensitive to sympathomimetic action, and these arterioles constrict when there is alpha-1 adrenergic activity. Now when you take blood pressure here, right, if left heart is contracting, the pressure which is present over here, that is called systolic blood pressure. And when left heart start relaxing, when left heart undergoes diastole, naturally blood try to go back, but this valve is, aortic valve is closed, and when aortic valve is closed, as left ventricle is relaxing, it means that connection of arterial tree with the left ventricular chamber is lost, right? During the diastole, aortic valve closes. Is that right? So there is, during diastole, no blood is coming from the ventricle to arterial system, right? Now, what will be the pressure maintained in arterial system during diastole? The blood pressure which is maintained in the arterial tree during the diastole does not depend mainly on cardiac output, because at that very moment there is no cardiac output. Now, the pressure of blood here depends on which factor? It depends on, yes, arteriomotor tone, right? For example, if arterioles relax, if arterioles totally relax, during diastole, most of the blood will move forward and there will be less blood in major arterial tree and blood pressure will drop. Which blood pressure will drop? Diastolic blood pressure. Am I right? So, during the diastole, if arterioles are open or there is arteriolodilation, blood will very rapidly move forward from the major arterial tree to the venous side, right? And pressure, diastolic blood pressure will fall. Opposite to that, if you constrict arterioles, classical example is alpha 1 adrenergic stimulation. If you constrict arterioles, then during the diastole, blood cannot move easily forward, because for the movement of the blood, total peripheral resistance is increased. So whenever total peripheral resistance is increased, right, it becomes difficult for the blood to move forward from arterial tree towards the venous side. So blood is retained here and pressure here is maintained at high level. So it means whenever you will open the arterioles, pressure in the major systemic circulation will drop, pressure during the diastole. And if you constrict the arterioles during the diastole, blood will be trapped here, even though there is no blood coming here during diastole. But if during diastole arterioles are constricted, significant amount of blood is trapped here and we say diastolic blood pressure is elevated. The whole purpose of this talk is to tell you that blood pressure maintained in systemic arterial tree during the diastole mainly depend on total peripheral resistance. These arterioles are like taps. You know tap? You open the tap, pressure in the main pipe is low. You close the tap, pressure in the main pipe is high. So today onward, whenever we talk about there is any drug which is producing arterioconstriction, that is taking total peripheral resistance up, that is taking diastolic blood pressure up. And again, what we infer out of it, the next time someone say that this is a drug which is mainly arteriolodilator, it means next time when you give a person arteriolodilator drug, as soon as arterioles will dilate, blood from systemic arteries will run distally and diastolic blood pressure will drop. Is that right? So let's come back after this basics, that whenever you give alpha 1 adrenergic agonist, arterioconstriction will occur and most of the alpha 1 associated vascular beds and total peripheral resistance will increase, and that will result into, yes, increased diastolic blood pressure. Am I clear? This is the direct result of alpha 1 receptor stimulation on arteriolosmooth muscle. Any question up to this? There's no question. Okay. But there is one more thing, that alpha 1 adrenergic receptors are also present on the veins, on the venules and veins. So it means whenever you give alpha 1 agonist drug, it means there will be venoconstriction as well. Is that right? Whenever you give alpha 1 agonist drug, there is, yes, venoconstriction as well. And you know, 70% of your blood volume is normally present in venous side. Again listen, right now you are sitting comfortably. and you have about 5 liters of blood in your body, I suppose. If you have 5 liter blood in your body, 70% of that 5 liter blood is right now present on your venous side. It means venous vessels, venous channels have the maximum capacity physiologically to hold the volume of the blood. That is why venous vessels are also called capacitance vessel. And that is why I told you that arterial vessels are not capacitance, they are resistant vessels. When you change the diameter of arterioles, you change the resistance in vascular system. When you change the diameter of veins, you change the capacity of the system. This is a very important point. Now listen, when you give alpha 1 stimulant, not only they produce arterioconstriction, they also produce, yes, venoconstriction. And because in the veins, a lot of blood is there, a little venoconstriction will push, squeeze, little venoconstriction, alpha 1 mediated venoconstriction will squeeze the blood to the right heart. So how we should say this thing? Alpha 1 receptor stimulation produces venoconstriction, and venoconstriction squeezes the blood volume towards the heart. And when there's a lot of blood is moving towards the heart, we say there is increased venous return. What is that? There is increased venous return. So all alpha 1 stimulant, right, they produce, yes please, venoconstriction, and when there is systemic venoconstriction, that result into increase, yes, venous return to where? Of course to the heart, right heart. And when right heart will receive more blood, Frank-Starling's law. When alpha 1 drug stimulates the venous smooth muscle, right, venoconstriction occurs, it squeezes the blood from the veins to the heart. When right heart is overfilled, it is overstretched. Frank-Starling law is more you stretch the myocardium, more strongly it contracts within physiological limit. So when there is increased venous return, there is, yes, increased venous return, that will lead to increased end diastolic volume. At the end of the diastole, there will be more blood filling here, and that will lead to increased, yes, stretch on the myocardium, and Frank-Starling law, there will be increased myocardial contraction, and there will be increased stroke volume, and there will be increased cardiac output. And of course, when right heart cardiac output will increase, there will be increased venous return to the left ventricle. And left ventricle will have increased venous return. It will also have increased, yes, and diastolic volume. And Frank-Starling law operate to the left ventricle also. So as there were more increased venous return, it will go stretch the right ventricle, it increases its cardiac output, then venous blood going to the left ventricle increases, left ventricle gets stretched, and then more you stretch, more it contracts within physiological limit. So it will contract strongly, and that will lead to, yes please, increase, yes, stroke volume, which will eventually end up into, yes, increased cardiac output. Is that right? So whenever there is alpha 1 mediated venoconstriction, increased venous return lead to increase end diastolic volume, increase stroke volume, increase cardiac output. When there is increased cardiac output, let's go to this example. When there is increased cardiac output, it means that during the systole, of course cardiac output is during the left ventricular systole. So during the left ventricular systole, whenever there is increased left ventricular filling, there is increased cardiac output. Whenever there is increased cardiac output, the volume here is less than normal or more than normal? More than normal. So during the systole, more than normal amount of blood will come to the systemic arterial side, and during the systole, these will be stretched and having higher pressure, and we say that systolic blood pressure will be increased. So what is systolic blood pressure? Now I will work into return fashion. What is systolic blood pressure? Systolic blood pressure is the blood pressure maintained in major systemic arteries during the left ventricular systole. Is that right? It means that systolic blood pressure is the blood pressure you are measuring in major arterial tree when left ventricle is filling the arterial tree. It's very logical that if cardiac output is more, then systolic blood pressure will be more, and if cardiac output is less, systolic blood pressure will be, yes, less. It's so easy to understand. So what we will say, increased venous return will lead to, yes please, increased venous return will lead to increase end diastolic volumes in the ventricles, and that will lead to increase stroke volumes, will eventually lead to increase cardiac output, and that will translate into, yes, increase systolic, yes, blood pressure. So in all this talk, what did we learn? We learned that systolic blood pressure depends mainly on cardiac output, because when systolic blood pressure is the blood pressure in major artery during systole, diastolic blood pressure is the blood pressure in major artery during diastole. During the systole, the pressure here mainly depends on how much blood is coming from the heart, right? So it means systolic blood pressure depends mainly on cardiac output, and during diastole, aortic valve closes, so no blood is coming during the diastole, no blood coming from the ventricle to here. Now during the diastole, how much will be pressure here? It depends on how fast blood can go from major arterial system to the capillaries and veins. If arterioles are open, total peripheral resistance to blood movement is less, blood during the diastole will move very fast forward and pressure will be less here. But if there is arterioconstriction, these taps are closed, then during the diastole blood cannot move forward rapidly and pressure here will be high, right? So in a nutshell, next time when you say that blood pressure is systolic over, yes, okay, I must say that someone has a blood pressure of 120 by 80 millimeter of mercury, right? Of course you know 120 is systolic, and of course you know that it is diastolic blood pressure, and then you know systolic blood pressure mainly depend on cardiac output. Mainly, there are other factors also, but mainly cardiac output. And we know diastolic blood pressure depends mainly on total peripheral resistance. Is that right? Now it is so logical and so easy to understand that whenever you will change the cardiac output, which component of blood pressure will change? Systolic. Whenever you will change the total peripheral resistance, which component of blood pressure will change? Diastolic. Is that right? Let me do a little trick with you. Just a very simple understanding of this fact. A very elementary graph. Let's suppose this is blood pressure of a thorough gentleman. It's 120 millimeter of mercury systolic and 80 millimeter of mercury diastolic, right? And so it means right now this is his blood pressure, right? I give a drug here. And blood pressure become like this, right? Systolic is not changed, but diastolic come down. So his blood pressure is, here blood pressure was 120 by 80. Here blood pressure is 120 by suppose 60. What do you think? What the drug has done? Yes, it has done arteriolodilation. This drug is arteriolodilator because arterioles dilated and during the diastole blood ran away from the major vessels and pressure dropped. Do you need to have a diagram or you really understand? Okay. Now I give another drug here. Suppose this was drug A. Let's suppose I give a drug B. And now systolic remain the same, but now his blood pressure has changed. his blood pressure after the drug B is 120 by 100. Yes. What is this drug doing? Arterioconstriction. Is that right? So you see, the drugs which are arteriolodilator, they bring the diastolic blood pressure down, right? Okay, I will make the same diagram. So here the drug opened up these points during the diastole, right? When they open up, diastolic fall. Here the drug has constricted these points, so blood was maintained here during diastole and pressure went up. Now let's talk about one more drug. We have given another drug, and now suppose drug C here, and we see that blood pressure has altered in this way. And what is the change in the blood pressure is, now it is okay, this is normal, this is normal, but this has elevated, so it is 140 by 80. So what has happened? Diastolic blood pressure is normal as in the beginning, right? Systolic blood pressure has increased. It means when you took the blood pressure here, during the systole, it was more than usual, but during diastole it was normal. So what is the change? What drug has done? Increased cardiac output. Here the drug has increased cardiac output. Because there is increased cardiac output, during systole this was overfilled and pressure during the systole was high, so systolic blood pressure went up. Am I clear or not? All of you are clear? Now we do another graph. We give another drug. It is still going 120 by 80 now, right? 120 by 80, and now we have given a drug, and this is the change. Now blood pressure is 100 by 80, and this was the drug's D. Yes, what we have done? We have given a drug which has significantly reduced the cardiac output, and when reduced the cardiac output, systolic blood pressure dropped. Am I clear? So next time when I say a drug is mainly changing the total peripheral resistance, it is changing the diastolic blood pressure. When we say drug is mainly changing the cardiac output, it means it is modifying the systolic blood pressure. Okay, let's do another drug here. I give another drug here. It is F. F stand for F only here, right? And you see what happened here. It is 180 by 40. What has happened? The drug has significantly increased cardiac output and dilated the arterioles. So when cardiac output increased too much, during systole it stretch out, pressure is very high. But as soon as it blocked, because arterioles are very much relaxed, rapidly blood goes forward and very little pressure is maintained here. Am I clear? If you want to continue, we can do one more experiment. Continue from there. 120 by 80. We do another experiment, and this is the action of the drug. Blood pressure is now 100 by 90. What drug has done? It has brought the systolic blood pressure down. It means cardiac output is less, and diastolic blood pressure has gone up. It means, arterioconstriction. You are so intelligent people. It's a pleasure to teach you. Is there any question about this? So, now we come back. We were talking about that vascular smooth muscle is constricted by alpha 1 adrenergic actions, and arterioconstriction increases diastolic blood pressure, and venoconstriction increases cardiac output and systolic blood pressure, right? Then any other action of the alpha 1 receptors. When we give a drug which will stimulate alpha 1 receptors, number 1, it will produce vasoconstriction. Number 2, from previous lecture, what happens to pupil? Pupil will constrict or dilate on alpha 1 stimulation. Pupillar dilatation occur. You forget. You remember there were some beautiful eyes like this, and this is your dilator pupillae. This is your dilator pupillae, and dilator pupillae have which receptors? Alpha 1 adrenergic receptors. When alpha 1 adrenergic receptors are stimulated here, dilator pupillae will constrict, and when dilator pupillae will constrict, right? When dilator pupillae will constrict, then naturally pupil will dilate. So there is pupillar dilation, which is also called mydriasis. Right, so alpha 1 drug, alpha 1 stimulant, especially if they are instilled in the conjunctiva, they can stimulate the dilator pupillae and produce mydriasis. Right, then we can come to, you remember there was some muscles attached with the, very tiny muscles attached with the hair follicle. Yeah, pili, erector pili, right? And which were the receptor there? Alpha 1 receptors. You remember when dog was after you and your hair stand up, right? Because alpha 1 receptors are there. So that will produce increase piloerector activity. Then alpha 1 receptors are very importantly present on urogenital system somewhere. Yes, alpha 1 receptors. Alpha 1 receptors, they are present in uro, especially about the male, that's very important. Yeah? Erection of the penis. Oh my God. No. Look, let me tell you one thing. Erection of the penis is parasympathetic activity. You know, males cannot achieve good erection if they are not mentally relaxed. As females cannot get wet if they are not mentally relaxed. A female who is very anxious and afraid and worried about many things, she finds it difficult to have wetness. Same is true about males. They cannot get erection if they are under financial burdens or office problems, or they have to give some exam, nasty exams in medical sciences, right? Things like that. If they are really worried about that. So don't tell me next time that erection depends on alpha 1 receptors. Erection is mainly parasympathetic activity. We will talk about that later. I'm talking about in male urogenital system, what is the role of alpha 1 receptors? Ejaculation. Ejaculation is sympathetic activity. A male who has a full erection for a long time, the sympathy of his biological system that he is capable of ejaculating and getting relieved. Is that right? And that depends on which activity? Alpha 1 stimulation. Is that right? You may be thinking, I'm just telling, is it having some medical importance or not? It has a big medical importance. There are advantages and disadvantages. Let me tell you first of all. Prostate gland. Prostate gland has smooth muscles or not? Yes, probably that's the only gland which has well-defined smooth muscles, right? So prostate gland has smooth muscles, and smooth muscles of the prostate gland have alpha 1 adrenergic receptors, right? So this is your urethra passing through the prostate tissue, right? And in the prostate tissue there are alpha 1 adrenergic receptors, right? And when these alpha 1 adrenergic receptors are stimulated, smooth muscle contract, right? They help in ejaculation. But there is some pharmacological importance. You know, the men, as they get senior citizens and elderly and more powerful, their prostate also grow, right? And when their prostate grow, powerful means they financially may become or socially become more powerful, but prostate unfortunately also grow. And prostate may press the urethra, and person may have a condition called benign prostatic hypertrophy, right? BPH, right? Right, BPH. benign prostatic hypertrophy. Now, there are so many ways, there are so many surgical and medical ways to treat benign prostatic hypertrophy. One way to manage these patients symptomatically is that patient with BPH, we should give some drug, we should relax the prostate smooth muscle. If prostate smooth muscle relax, prostate will not clamp the urethra, will not compress the urethra. So what type of drugs you will give? Alpha 1 stimulant or agonist or antagonist? Yes, antagonist, very good. So what we do, that you have to remember that alpha 1 receptors are present in the smooth muscle of the prostate as well, and this has clinical relevance that there are drugs which are alpha 1 receptor blocker, right, and specifically on the prostate, and they can relax the prostate and reduce the symptoms of benign prostatic hypertrophy and hyperplasia. Is that right? But there is another thing, as I told you that male's ejaculation is dependent on sympathetic activity, and that sympathetic activity is mediated through alpha 1 adrenergic receptors. Males will be very, very unhappy when they are giving what kind of drug? Alpha 1 blockers, right? That produces sexual dysfunction in males. Is that right? So that is another relevant point that you have to remember. Male urogenital system has alpha 1 adrenergic receptors, and it has two clinical relevance. Number one, you can give alpha 1 receptor blocker to relax the prostate, and it will relieve the urethral urine flow, and symptomatically relieve the problem related with benign prostatic hypertrophy. And secondly, whenever you are giving alpha 1 receptor blockers, those males may be very, very unhappy with you, some of them, because they have ejaculatory problems. Why we use alpha 1 receptor blocker very frequently? We want to create ejaculatory problems in males. Yeah. Yeah, hypertension. Alpha 1 blockers are excellent antihypertensive drugs. I told you in last lecture there is something called prazosin and trazzosin. Alpha 1 blockers, prazosin and trazzosin drug block the alpha 1 receptors and produce arteriolodilatation, a little bit venodilation. And arteriolodilatation and venodilation will bring the blood pressure down. But some males, after taking prazosin or trazzosin or related drugs, may experience ejaculatory problems. Is that right? No problem? Okay. So then alpha 1 receptors are also present on internal sphincter. So alpha 1 stimulant will increase the tone of internal urethral sphincter, right? Then, so these were some important alpha 1 action. Next time, whenever I say there is a drug which is having alpha 1 stimulatory action, it is arterioconstrictor drug, it is venoconstrictor drug, it is, if it is stimulant, it will constrict even the smooth muscles and prostates, and if in sufficient amount present on the dilator pupillae, it can produce mydriasis, right? That is why alpha 1 stimulant sometimes can produce urinary retention, because internal sphincter may be, urethral sphincter may be stimulated too much. Is that right? No problem up to here? Right. After the alpha 1 mediated alpha 1 actions, now we go to alpha 2 actions. Right? What are the alpha 2 actions? In the last lecture, I told you a lot about alpha 2 receptors. Number one, alpha 2 receptors were present pre-synaptically in the neurons. If it is adrenergic neuron, and suppose it is releasing norepinephrine on the target tissue, right? A part of the norepinephrine, yes, part of the norepinephrine act as a negative feedback on the presynaptic receptors. This presynaptic receptor is, yes please, alpha 2 adrenergic receptors, right? And when norepinephrine stimulate alpha 2 presynaptic alpha 2 receptors, they inhibit the nerve ending function, and further release of norepinephrine is inhibited. Further release of, so alpha 2 receptors which are present presynaptically are release inhibitor for sympathetic nerve endings, right? So alpha 2 receptors which are presynaptic, right? Alpha 2 adrenergic receptor will lead to, yes, they will lead to reduced norepinephrine release from the nerve ending, of course. This is one action of alpha 2 adrenergic receptor. What is the another action of alpha 2 adrenergic receptors? Yes, alpha 2 adrenergic receptors are also present on insulin producing cells. Insulin is produced by which cells? I think you must be remembering there is something called pancreas, and in the pancreas there are islets of Langerhans. In the islets of Langerhans there are beta cells, and beta cells of islets of Langerhans have alpha receptors. Beta cells of islets of Langerhans have alpha 2 receptors. Suppose this is the beta cell, right, which is normally responsible to produce, yes, insulin, but this cell is loaded with alpha 2 adrenergic receptors. So whenever these alpha 2 receptors are stimulated, they are again linked with G inhibitory protein intracellularly, and they inhibit the function of beta cells of pancreas, and insulin release is inhibited. So they reduce the release of norepinephrine, they also reduce the release of, yes, release of insulin, right? They reduce the release of insulin. Then any other function of alpha 2 receptors? You know, on the lipocyte, adipocytes, this is adipocyte, and adipocytes, you may be remembering they have beta 3 receptors, beta 3 adrenergic receptors which are modified beta 1 receptors, right? But actually only very good students know that lipocytes also have alpha 2 adrenergic receptors, right? Actually, when you stimulate the beta 2 adrenergic receptors, right, it increases lipolysis. It increases lipolysis. But when you stimulate alpha 2 adrenergic receptors, it will decrease lipolysis. So it means on the adipocytes, right, there are alpha 2 adrenergic receptors as well as beta 3 adrenergic receptors. Beta 3 adrenergic receptors are stimulatory for lipolysis, and alpha 2 receptors are inhibitory to lipolysis. So naturally, if you cannot remember both type of receptors, forget about alpha 2, but please remember beta 3 adrenergic receptors, which are more important, right? But if you are really too good, you must remember that on the adipocytes or lipocyte, there are adrenergic stimulatory receptors, beta 3, and adrenergic inhibitory receptors, alpha 2. So it reduces, yes, lipolysis of lipolysis from adipocyte. Then any other function of alpha 2 receptor, if alpha 2 receptors are stimulated again, when alpha 2 receptors are stimulated, nerve endings release less norepinephrine, beta cells release less insulin, adipocytes release less free fatty acid, and when alpha 2 receptors are stimulated, right, she is saying blood pressure, alpha 2 stimulant, which drug you are talking about? Clonidine, I think. Clonidine act in central nervous system, stimulate alpha 2 receptor and reduce sympathetic outflow, that is by reducing the norepinephrine release, right? We'll talk about that later. Alpha 2 receptors are also present at some part of the body or some components of the body where nerve endings are not releasing norepinephrine. Alpha 2 receptors are present, okay, I will give you a hint. Alpha 2 receptors are present on some components of the blood. Yeah? Platelets, yes, very good, excellent. So alpha 2 receptors are also present on the platelets, right? There are alpha 2 adrenergic receptors, and when they are stimulated, yes, when alpha 2 receptors are stimulated on the platelets, platelets get activated, and you know, activated platelets undergo clumping, aggregation, right? So alpha 2 receptor stimulation can lead to platelets aggregation. They can lead to platelets aggregation, right? So what can we do? You know, pharmacologically we have drugs which can block the alpha 2 receptors, right, and reduce the platelet aggregation. They are still working to make some more efficient drugs to reduce the platelet aggregation, right? So again, let's compare fastly. If someone asks what are the alpha 1 action, arterioconstriction, venoconstriction, stimulation of, yes, prostate smooth muscle and internal urethral sphincter plus mydriasis plus pili erection, right? That's good. Alpha 2 action. Alpha 2 actions are reduced norepinephrine release from the sympathetic nerve endings, reduced release of insulin, reduced lipolysis by beta cells, and increased aggregation of the platelets. Let's have a break. Right, so we have already discussed what are alpha 1 action and what are alpha 2 action, right? Now we'll talk about beta 1 action and beta 2 action. Beta 1 action means the typical action produced in our body when beta 1 adrenergic receptors are stimulated. When I mention in future that there are beta 2 action, actually I mean that what are the typical actions produced in our body by stimulation of beta 2 adrenergic receptors. So let's first talk about typical beta 1 action. You must be knowing that beta 1 receptors are distributed in three important tissues. What are those tissues on which beta 1 receptors are present? Yes, please. Number one is your heart. Your heart has beta 1 receptors. In the heart, you know, there is SA node, there is AV node here, bundle of His and Purkinje system. Now, beta 1 adrenergic receptors are present on, yes, SA node. They are present on atrial myocardium. They are present on ventricular myocardium, as well as beta 1 receptors are present on AV node, and they are also present on special conduction system, right? It means beta 1 receptors in the heart are distributed most of the areas. Why I am specially stressing that there is a good beta 1 adrenergic receptor distribution, because when we talk about cholinergic muscarinic receptor distribution, that is different. You know, as vagus nerve releases acetylcholine on the heart, and cholinergic muscarinic receptors are not distributed on all the heart. Cholinergic receptors are distributed mainly on SA node and AV node, little on atria, and not on ventricles. So cholinergic action mainly affect the SA nodal activity and AV nodal activity, but adrenergic action affect SA nodal activity, AV nodal activity, also affect the atrial and ventricular contraction. Is that right? Now, let's suppose if you have a drug which can stimulate beta 1 receptors. Can you tell me a drug which can stimulate beta 1 receptors? Yes, please. There are so many intelligent doctors sitting here. Yes, this any drug, single drug which can stimulate beta 1 receptor. Let me tell you, this drug is going to be important because in failing heart, it can stimulate the heart and increase cardiac output. Now, yes, enalapril. I think enalapril was somewhere like angiotensin converting enzyme inhibitors, right? It is still. Yes, digoxin. Remember, this answer is wrong. Digoxin is not adrenergic drug. Digoxin basically stimulate vagus nerve to release more acetylcholine. Plus, digoxin can block the sodium-potassium ATPases in the myocardium, so that less sodium goes out of the myocardial cell. And when sodium accumulates into myocardial cell, intracellular sodium is exchanged with extracellular calcium. and then calcium comes in and increase myocardial contractility. That is the mechanism of action of digoxin. That has nothing to do with the beta-1 adrenergic receptor stimulation. Any drug which can stimulate beta-1 adrenergic receptors. Yes, Gavin. Okay, he comes with a perfectly wrong answer. He says atenolol. Atenolol is beta-1 blocker. My friend, I'm asking about beta-1 stimulant. You know, yeah, dopamine and dobutamine. Dopamine and dobutamine, they have a beta-1 stimulant action. We'll talk in detail later when we'll talk these drugs into detail. But for a while, you must know dopamine and dobutamine. These are beta-1 stimulant, right? Especially dopamine is cardiostimulant with renovascular dilator. Dopamine stimulate the heart and dilate the renal vessels and improve renal blood flow. Dobutamine mainly stimulate the heart. Okay, it's a little out of the way, but it's worth talking about. If you come across a patient where heart kinetic activity is slow, heart is pumping very poorly, cardiac output is very low, and due to low cardiac output, renal blood flow is also less. For example, a patient who is undergoing shock, a patient who is undergoing shock, circulatory shock due to cardiac failure, and heart is not pumping well, right? And of course, when heart is not pumping well, cardiac output to brain is also less and sympathetic overflow occur and renal vessels constrict. And if renal vessels constrict intensely, that may produce the risk for acute tubular necrosis. So when you have a patient with a combination problem, a patient with reduced cardiac output with renal vasoconstriction and threat of acute tubular necrosis, the drug of choice to stimulate the heart is dopamine, because dopamine has beta-1 stimulant action, plus it stimulates dopamine receptor on renal vasculature to dilate the renal vasculature. So dopamine is a wonderful drug, even though it has to be given by intravenous infusion, that it can, by beta-1 action, it can stimulate the heart and increase cardiac output, and simultaneously it can dilate the renal vessels and reduce the risk of acute tubular necrosis. But if you come across another patient, his main problem is reduced cardiac output due to reduced contractility of the heart, but renal blood flow is not significantly reduced, that patient should not be given dopamine, because you don't need renodilation there. Again, the patient, second patient, which has main problem with the reduced cardiac output due to hypokinetic heart which is poorly contracting, right? But renal blood flow is acceptable. You want a drug which specifically stimulates the beta-1 receptors, then drug is not dopamine, drug is dobutamine. This is the real basic difference in these two drugs, other than the spellings, right? Dobutamine is cardioselective stimulation and dopamine is cardiostimulant plus renodilator. Okay, let's come back. We were talking about the beta-1 adrenergic actions in your body, the typical beta-1 action. If you forget everything, please remember cardiostimulation. Whenever we say beta-1 stimulation, cardiostimulation. Whenever we say beta-1 blocker, cardio inhibition. Is that right? No problem? And of course, you know that when adrenergic drugs will stimulate the SA node, adrenergic agonist, beta-1 stimulant, when they will stimulate the SA node, there will be increased chronotropy. And if beta-1 drug, beta-1 stimulant, stimulate the AV node, yes, what is that? When AV node is stimulated, yes, when there is AV node stimulation by beta-1 adrenergic drugs and conduction through AV node become more positive, dromotropy. And when beta-1 receptors on, yes, specialized conduction system are stimulated and excitability yes, excitability, electrical excitability of Purkinje system increases, and specialized conduction system has increased excitability when there is more norepinephrine or epinephrine stimulation on beta 1 receptor. What we call it? Positive? Don't tell me positive inotropy. It is positive bathymotropic. Positive bathymotropic. It has nothing to do with bathroom. Bathymotropy. Yes, I must remind. Because once I ask a student, what is positive bathymetropy? He say when in the washroom you release a lot of adrenaline and your heart rate becomes fast. Right? There are people like that, don't worry. So remember, positive bathymetropy means there is increased excitability of specialized conduction system. Is that right? And when SN node is excited, that is positive chronotropy. Bathymetropy, it is important to know because overexcitation of specialized conduction system by the epinephrine and norepinephrine produces arrhythmia risk, tachyarrhythmia risk. When there is overstimulation of specialized conduction system by adrenergic beta 1 stimulation, that may increase the risk of tachyarrhythmias. Then beta 1 receptors are of course present on the contractile myocardium. So when beta 1 receptors are stimulated on the, yes, atrial myocardium and ventricular myocardium, and degree of myocardial contractility is increased. Degree of myocardial contractility is increased. This is called positive inotropic. Now I think there is something here I need to explain more clearly. Look, let's suppose on this there is contraction, and on this is the time, right? Let's suppose before getting beta 1 stimulation, patient has contraction, myocardial contraction, which goes to the peak and then come to the relaxation, right? You know, during the systole, left ventricle contract. So this is systole, and left ventricle start contracting, pressure goes to the peak, myocardial contraction has gone to the peak, and then myocardium relaxes. Is that right? This is without exogenous beta 1 stimulation. Now let's suppose you give injection of a drug which is beta 1 stimulant. After the injection, this profile will change. After the injection, after the beta 1 stimulation, look at it. Contraction will go like this and this. Now what are the real alteration? Number one, the total degree of contraction has increased because before the beta 1 stimulation, degree of contraction was up to this. You know this. After the drug, total strength of contraction has been increased. This increase in the strength of contraction, yes, this increase in the strength of contraction is called positive inotropy, right? That strength of contraction has significantly increased. Before, strength of contraction was here, now strength of contraction is there, right? But there is another thing which has increased, you know, velocity of contraction and relaxation. Let me show you how. Look, contraction started from here, and to reach to the peak, it took this much time without beta 1 stimulation, right? Contraction took so much time to reach to the peak. But after the beta 1 stimulation, you see contraction went very rapidly to the peak. Now peak could be achieved only in this time. So it means that without beta 1, heart was contracting slowly and for lesser strength. With beta 1 stimulation, heart contract with high velocity and with higher strength. This increase in velocity, that to reach to the strength, it is taking shorter time. Are you understanding me or not? Right? This is called positive kalinotropy. What is that? Positive. This is this thing that heart previously was taking so much time to reach its peak contraction, but in the presence of beta 1 stimulant it took a much less time to reach to the peak. This effect of beta 1 stimulation is called positive kalinotropy. Yes, positive kalinotropy. So let me repeat it. If I say beta 1 stimulation produces positive chronotropy, it means they stimulate SA node, pacemaker, normal pacemaker activity. When I say that beta 1 stimulant produce positive dromotropy, it means they increase conduction through AV node. When I say that beta 1 stimulation produce positive bathmotropic, it means it increase excitability, electrical excitability of myocardial cells, right? Especially specialized conduction system. When I say there's positive inotropy, it means there's increased strength of contraction in myocardium. When I say there is positive kalinotropy, I mean there is increased velocity of contraction of the myocardium. So actually, beta 1 stimulant are positive inotropic, positive chronotropic, positive dromotropic, positive bathmotropic, positive inotropic, and positive kalinotropy. This has clinical significance because when there is positive chronotropy, there is increased heart rate. Is that right? And when there is positive inotropy and kalinotropy, there is increased stroke volume. So it means due to positive chronotropy and due to positive inotropy and kalinotropy, right, there is increased heart rate plus there is increased stroke volume. It means there is increased cardiac output. It means there is increased systolic blood pressure. So all the drugs which are direct cardiostimulant, which are positive chronotropic and positive inotropic, they increase the cardiac output and they increase the systolic blood pressure. And it's very easy to understand that if there is a drug which is beta 1 blocker, can you tell me any drug which is beta 1 blocker? Like atenolol, metoprolol. So if you give up your patient beta 1 blocker, that will be acting as negative chronotropic, negative dromotropic, negative bathmotropic, negative inotropic, negative kalinotropy. And these patients, when heart rate will decrease with beta 1 receptor blocking, and there is decrease in contractility and stroke volume, there will be decrease in cardiac output and there will be decrease in systolic blood pressure. Is that right? So one of the typical action of beta 1 agonist is cardiostimulation. Is that right? And one of the typical action of beta 1 blocker is cardio inhibition. Fine. So this was one thing, that beta 1 receptors are present on myocardium. Then we come to the second tissue on which beta 1 receptors are present abundantly. If you remember previous lecture, you remember that there was, yes, juxtaglomerular apparatus in the kidney, and juxtaglomerular apparatus also has lot of beta 1 receptors. You must be remembering that juxtaglomerular apparatus, right? This is macula densa. Here are your arterial, afferent and efferent arterioles, right? All of this is juxtaglomerular apparatus, right? And juxtaglomerular apparatus is having beta 1 adrenergic receptors. So whenever beta 1 stimulant are present in your body, they stimulate the juxtaglomerular apparatus and increase the release of renin, and renin angiotensin aldosterone axis is stimulated, and then angiotensin 2 mediated. Of course, when renin is more, angiotensinogen is converted into angiotensin 1, then in the lungs angiotensin 1 is converted into angiotensin 2, and then angiotensin 2 produce arteriolo. Okay, before I tell you these things, I want to know, ma'am, angiotensin 2 is a stronger vasoconstrictor or epinephrine is a stronger vasoconstrictor? Yes, ma'am. I'm about to be impressed by you. Yes. Okay, yes, sir. Epinephrine is the stronger vasoconstrictor or angiotensin 2 is stronger vasoconstrictor? I don't know, you have to decide. Yes. You think angiotensin 2 is more powerful than epinephrine? Okay, Dr. Sergio Mauri says angiotensin 2 is more powerful than epinephrine and norepinephrine. Anyone who does not agree with him, raise your hand. Yes, many people raise hand. All of you are wrong. Angiotensin 2 is 1,000 times more powerful than epinephrine and norepinephrine on weight basis as a vasoconstrictor. Why? Yes, he knew it. That's good. Yes, he knew it. Yes. And then he must know one more thing. The drugs which slightly reduce angiotensin 2 level significantly control blood pressure. That's the point to be made. Right? So, what is happening? Anyone who is beta 1 stimulant, it increase renin, angiotensin, aldosterone excess. Right? But let's suppose, if we give a drug which is beta 1 blocker, beta 1 blocker will not only act as cardio inhibitor, but beta 1 blocker drug will block beta 1 receptors on juxtaglomerular apparatus, and renin production in your body will be less. And when renin will become less, then angiotensinogen into angiotensin 1 will be less, and angiotensin 1 converted into angiotensin 2 will be less. Then angiotensin 2 mediated arterioconstriction will be less. Then diastolic blood pressure will be less. Then angiotensin 2 mediated venoconstriction will be less. Venous return will be less. Cardiac and diastolic volume will be less. Cardiac output will be less. And systolic blood pressure will be less. Even aldosterone will be also less. You know, angiotensin 2 not only constrict arteriole, not only constrict veins, angiotensin 2 also stimulate zona glomerulosa to produce aldosterone. So when angiotensin 2 is less, then aldosterone is less, then aldosterone mediated salt and water retention is less, then blood volume is less. Venous filling is when blood volume is less, then venous filling is less, then venous return is less, then cardiac filling is less, then cardiac output is less, then systolic blood pressure is less. That is why those drugs which reduce angiotensin 2 level in the body are very, very good antihypertensive drugs. But here we should make a point that beta 1 blocker drugs reduce the blood pressure by cardio inhibition and also reduce the blood pressure by inhibiting the renin, angiotensin, aldosterone system. Am I clear? Then any other beta 1 actions? Of course, on the lipocytes, adipocytes. You know, your friends adipocyte keep on accumulating in your body, so frankly, right? They also have modified beta 1 receptors which are called beta 3 adrenergic receptors. And if there is a drug which can stimulate these adrenergic receptors on lipocyte or adipocyte, that will produce lipolysis. And if you have a drug which can stimulate beta 1 receptors, that will produce lipolysis. Is that right? And if there is a drug which block beta 3 receptors, of course that will prevent lipolysis. Am I clear? So next time if I say there is a drug with beta 1 action, you know it. It's cardiostimulant and it is amplifying production of renin and producing renin, angiotensin, aldosterone system stimulation and disrupting some lipocyte function. Right, now we come to beta 2 action. Is that right? Now we come to beta 2 actions. What are the typical beta 2 adrenergic receptor mediated actions in your body? Yes, beta 2 receptors. Number 1, you know, in the lungs there are beta 2 receptors present on, yes please, Yeah, where they are present? On bronchial smooth muscle. On bronchial smooth muscle, there are beta 2 receptors. These are bronchial smooth muscles. It's a very simple diagram. And on this smooth muscle, I bring it out, there are beta 2 adrenergic receptors, right? And beta 2 receptors are inhibitory receptors here. So when there is beta 2 stimulant, right, this will inhibit the contraction of bronchial smooth muscles, right, and that will end up into what? Beta 2 mediated bronchodilation. And this is clinically a very important concept. That when beta 2 receptors on bronchial smooth muscles are stimulated, that leads to beta 2 mediated bronchodilation. Yes. Pharmacologically, we take advantage of this mechanism in patients with asthma, patients who have generalized tendency, patients who have a tendency for generalized bronchoconstriction, like patient with asthma. In patient with asthma, we give beta 2 stimulant like albuterol or terbutaline. These are beta 2 stimulant drugs, and beta 2 stimulant drug can lead to bronchodilation. Am I clear? So this is one action of beta 2 stimulation on the bronchial smooth muscle. Do you think in bronchial tree or in the lungs there is any other action of beta 2 stimulation? I will be impressed again. Is there any other part of any other component of the lung where there are beta 2 receptors? Of course, there are beta 2 receptors present on bronchial smooth muscles, right? And whenever you stimulate them, there is beta 2 mediated bronchodilation. And clinical point is that beta 2 stimulant are used as bronchodilators like terbutaline, albuterol. They are bronchodilators. And you must also know beta 2 blockers like propranolol, which are beta 1 and beta 2 blocker. When you take propranolol, beta 1 and beta 2 receptors are blocked, and when pulmonary beta 2 receptors are blocked, then beta 2 mediated bronchodilation is lost and there is tendency of bronchoconstriction. That is why propranolol is contraindicated in patients with asthma, because in asthma patient propranolol will block the beta 2 receptors and normal beta 2 mediated bronchodilation is lost. You know, normally our body does have some circulating epinephrine and some norepinephrine which comes from the nerve endings, and this endogenous normal usual amount of adrenergic drive keep bronchi a little bit dilated. So as soon as you take propranolol, beta 2 mediated bronchodilation will be lost. In normal person it may not be significant problem, but a person who has tendency for asthma, he may precipitate severe bronchoconstriction. I was asking that is there any other component of the lung which has beta 2 receptors which may help in allergic asthma? Yes. Mast cells. You know, there is something called mast cells which play a big role in allergic asthma. Mast cells have many types of receptors, including the beta 2 receptors, mast cells. They also have beta 2 adrenergic receptors. And when these receptors are stimulated, mast cell membranes are inhibited, and membranes of mast cell and granules of mast cell is stabilized. So tendency of mast cell membrane to produce prostaglandins and leukotrienes is reduced, and tendency of mast cell granule to release histamine is reduced. Is it good for patient with allergic asthma or bad? My God, it is good. If I have allergic asthma, do you think my mast cell should be stimulated and release prostaglandins and leukotrienes and histamine? You don't want. Let mast cells sleep like dogs. We want them to be inhibited. Is that right? So there is an added advantage of beta 2 drugs, which are beta 2 stimulant, that not only they produce bronchodilation, which is the major action of beta 2 drugs in asthma, but beta 2 receptors on the mast cells are also stimulated, and beta 2 receptor, when they are stimulated on the mast cell, they inhibit the activity of mast cells. So mast cell chemical mediators are not released. So we can say the beta 2 stimulant drugs like terbutaline, albuterol, such drugs not only produce bronchodilation but they also stabilize the mast cells in the bronchial mucosa. Am I right? Clear? Okay. So this was beta 2 action on the bronchial smooth muscle. Then there are beta 2 action on the vascular smooth muscles. I told you in previous lectures that the blood vessels which go to the skin, they are having alpha 1 receptors. Blood vessels which are going to GIT, they are also having mainly alpha 1 adrenergic receptors. And blood vessels which are going to the kidney, they are also having alpha 1 receptors. But blood vessels which are going to the muscles, they are having more beta 2 receptors and less alpha 1 receptors. Blood vessels which are going to the skeletal muscle, those blood vessels, suppose I remove one smooth muscle here. This is smooth muscle from the blood vessel of skeletal muscle. It has more beta 2 receptors. These are all beta 2 receptors and very little alpha 1 receptors. Right? So when you give a drug which is mainly beta 2 stimulant, then beta 2 receptors will be stimulated and there will be beta 2 mediated relaxation of vascular smooth muscle in the blood vessels going to skeletal muscle especially. So skeletal muscles, blood vessels arterioles will relax, right? And peripheral resistance to skeletal muscle will be reduced. Now listen carefully. A drug which is purely alpha 1 stimulant, right, that will act on these alpha 1 receptors and produce vasoconstriction. And another drug which is mainly beta 2 stimulant will produce beta 2, that will produce beta 2 stimulation on these smooth muscles and relax. So it means that drugs which are alpha 1 stimulant, they produce arterioconstriction, and which are beta 2 stimulant drugs, they produce here arteriolodilation. It means that alpha 1 stimulant produce increased total peripheral resistance and beta 2 stimulant decrease total peripheral resistance. Is that right? Now you may be thinking, what is the clinical importance of this? Let me tell you. Right now I was telling you that endogenously normally there is some degree of epinephrine circulating in our blood. That epinephrine, endogenous normal epinephrine, produces a slight vasoconstriction in alpha 1 mediated arterioconstriction in cutaneous, splanchnic and renal circulation. And normally endogenously circulating epinephrine normally produces beta 2 mediated vasodilation in skeletal muscles. Is that right? And let me tell you something interesting now. Even though when we read medical literature, we say cutaneous blood vessels have which receptors? Alpha 1. But to be very critical, cutaneous blood vessel smooth muscle has lot of alpha 1, alpha 1 receptor, and little beta 2 also. To be very critical, there are some people who are really nasty and very critical. To be very critical, most of the places in our bodies have alpha 1 and beta 2 both. But when I say that this area has alpha 1 receptors mainly, I mean alpha 1 are abundant, far more in concentration than beta 2. Right? Now listen. There is some clinical importance. When you give a drug which is beta 2 blocker, beta 1 and beta 2 blocker drug is propranolol. Propranolol is beta 1 and beta 2 blocker. When you give propranolol, that will block the beta 2 mediated vasodilation to skeletal muscles. Are you understanding me? When these beta 2 receptors are blocked here, do you think when you do exercise and produce epinephrine and norepinephrine, and this epinephrine goes and through beta 2 mediated action, exercise induced epinephrine through beta 2 mediated action dilate the blood vessels to skeletal muscle. But if you are on propranolol, during physical exertion, beta 2 mediated vasodilation of blood vessels going to skeletal muscles is lost. If you have taken propranolol, beta 2 receptors here are blocked, then when you do physical exertion, beta 2 mediated vasodilation of skeletal muscles is blocked, lost. So there is reduced tolerance to physical exertion when you are on propranolol. There is reduced tolerance to physical exertion. Patient complains of fatigability. He does a little activity and feels more fatigued due to some central action of the drug and due to loss of beta 2 mediated vasodilation in the skeletal muscles. Another thing. Could you understand it or not? You could not understand. Okay, so let's start with the basic. Normally we have epinephrine circulating. Normally that act on the beta 2 receptors on skeletal muscles, blood vessels. Normally epinephrine, endogenous epinephrine keep the skeletal muscles vessels slightly dilated due to beta 2 mediated action. Is that right? So we say that in a normal person there is some degree of beta 2 mediated vasodilatation to skeletal muscle. Is that right? And when you do exercise, you get inhibited or stimulated. Your sympathetic nervous system gets stimulated during exercise. You are excited usually, right? When you do exercise, the level of epinephrine and norepinephrine is more in the blood, especially epinephrine, which is released by adrenal medulla. This circulating epinephrine during exercise, right, act on the beta 2 adrenergic receptors on skeletal muscles, blood vessel and produce beta 2 mediated dilation. So that increases blood flow to the skeletal muscle. So during exercise, skeletal muscles blood flow increase, number one due to beta 2 mediated vasodilatation, plus during exercise, skeletal muscle produce local factor which dilate the skeletal muscles blood vessel, right? Now you imagine you have taken propranolol. Propranolol block beta 1 receptor as well as beta 2 receptors. Is that right? Because when you have taken propranolol, beta 2 receptors are blocked on the skeletal muscles blood vessels, then yes, beta 2, you have loss of beta 2 mediated what? Vasodilation to skeletal muscles. So when you will do exercise, while you are on propranolol, do you think these blood vessels will dilate significantly? No. You will get tired easily. There are multiple reasons. When patients are on propranolol, they feel very fatigued with little exertion. There are some central action I will discuss later, plus this is one action. Another point which is clinically relevant, that our skeletal, these blood vessels which are going to the skin and going to the distal part of the limbs, these blood vessels have more alpha 1 receptors and less beta 2 receptor. Now listen, have you heard of a disease called Raynaud disease or Raynaud's phenomenon? Raynaud, R-A-Y, Raynaud's disease. Actually, you have never heard of things like this. Okay, you will hear. Right now, I'll tell you something. In Raynaud's disease, there is increased tendency of vasospasticity of distal blood vessels. Our distal blood vessels are having increased tendency to undergo vasoconstriction whenever skin is exposed to the cold. Normally when you are exposed to the cold temperature, when you are exposed to the cold, normally your blood vessels constrict. But in some people who are suffering with Raynaud's problem, when they are exposed to the cold, skin, distal blood vessels in the limbs constrict so severely that they develop severe cyanosis and even sometimes necrosis of fingers and severe Raynaud's disease. Is that right? In these patients who have a high tendency of vasoconstriction in the limb blood vessels, if you give them propranolol, a little beta 2 mediated vasodilation is also lost. You are understanding? So propranolol will be contraindicated in the patients with peripheral blood vessel disease like Raynaud's disease, because they are already having a tendency of vasoconstriction. At the top you give the propranolol and then there is loss of beta 2 mediated vasodilation and more severe constriction. Is that right? And so how many points about beta 2 receptors I was talking? Propranolol should not be given in a patient with asthma because beta-2 mediated beta-2 mediated bronchodilation will be lost. Propranolol should not be given to the patients with Raynaud's disease, peripheral vascular disease, because beta-2 mediated vasodilation will be lost. Am I clear? Then, so you know beta-2 actions, and the beta-2 actions which we have learned up to now. Yeah, there is another smooth muscle which is also having beta-2 receptors. Up to now we have said beta-2 receptors are present abundantly on bronchial smooth muscle. Beta-2 receptors are present abundantly on the vascular smooth muscle, and beta-2 receptors are present also on the myometrium of pregnant uterus. We mentioned previously that in the uterus, right, in the myometrium of the uterus there are beta-2 receptors also, and beta-2 stimulation lead to, yes, if you give a drug which is beta-2 stimulant, what it will do? It will produce dilation of what? Uterus dilatation. Drug is not Hagar's dilator. We don't use the term uterus dilation, that is what I am going to say. Right? If even theoretically or practically, even you are right that when you give us beta-2 stimulant, as bronchioles will dilate, uterus will also relax is a better term. Right? We don't say uterus is constricting and uterus is dilating. I don't know why, but this is what they say. Right? So, beta-2 mediated myometrial relaxation is achieved when you give beta-2 stimulant. And I told you previously, this has clinical importance, that when uterus start contracting, a pregnant uterus start contracting before time, there's premature labor pains and labor contractions, right, premature, and it threatens to produce premature birth of the baby. You can give beta-2 stimulant drug which will produce relaxation of the myometrium so that uterus should not threat to push the baby out before time. Am I right? What is this action called? If a drug produces relaxation of the uterus, this action of the drug has given a very specific name in medical literature. Someone who has done gynae-ob. Yes? Yeah? Pardon? Detergent? I'm saying if I give a drug to a female and that drug acts on the myometrial smooth muscle and relaxes them, right? So, drug action is called tocolysis. This action is called, in medical literature, tocolysis or tocolytic drug. Doctors have a special tocolytic drug, ritodrine, albuterol or terbutaline or ritodrine. These are all beta-2 stimulant. Ritodrine specially stimulates the beta-2 receptors on uterus, right? So, what are the typical beta-2 action? Bronchodilation, vasodilation, especially to the skeletal muscles, beta-2 action. There is relaxation of myometrium, of course only in the females, right? Then, no, I should tell you the basic information, right? So, then any other beta-2 actions? Any other beta-2 action? Beta-2 receptors are present on the liver, metabolic action. Oh my God, there is something called liver which has hepatocyte. There are also beta-2 receptors, adrenergic receptors of course, on the hepatocyte. You must be knowing that when you are under stress, epinephrine is released in the blood from adrenal medulla. Epinephrine will bind with the beta-2 receptors on the what? Hepatocyte, and that will give signal for breakdown of glycogen. Glycogen will break down into glucose and glucose will come out into blood. Am I clear? Glycogenolysis. So there is beta-2 mediated glycogenolysis on the hepatocytes. Is that right? Release of glucose. Do you think this thing has any importance, this information? Yes. There's physiological importance as well as pharmacological importance. Physiological importance is that that when you are under stress, as I told you, there was a big black dog after Mr. Gavin. That very moment, a lot of epinephrine come into blood. Epinephrine act on the hepatocytes through beta 2 receptors and do glycogenolysis and release a lot of glucose into his blood. So that glucose can be used by muscles and by the brain to fly away appropriately from the threat, right? It has pharmacological importance that you must know. There are beta 2 receptors on the liver cells. Very commonly used drug is propranolol. And if propranolol blocks, what is this funny thing? Beta 2 receptors. What will happen? The liver loses the capacity. Liver loses the capacity to release glucose by glycogenolysis when you have hypoglycemia. Now let me tell you another thing. Whenever you have hypoglycemia, listen carefully. Let's suppose due to any reason I get severe hypoglycemia. Hypoglycemia stimulates sympathetic nervous system strongly. Severe hypoglycemia. And sympathetic nervous system, number one, produces the signs of warning signs of hypoglycemia. What are the warning signs of hypoglycemia? Sympathetic overflow. Sympathetic overflow produces sweating, anxious look. In hypoglycemia, you become irritable and anxious. And in hypoglycemia, when there is oversympathetic flow, you develop tachycardia, palpitations, and when sympathetic overflow, tremors. Is that right? These are the warning signs, especially the patients who are diabetic patients, especially those diabetic patients who are insulin dependent. Listen carefully with both ears. The patients who are insulin dependent diabetic patients, they have a high risk to undergo hypoglycemic attack, because if I'm a patient who is insulin dependent, sometimes I may not take food and take insulin and I develop severe hypoglycemia, or sometimes I take insulin and food in normal amount but do some lot of physical exercise, I will develop hypoglycemia. So the patient who are insulin dependent diabetics, they have high risk of developing episodes of hypoglycemia. When they develop severe hypoglycemia, because they are taking insulin injections, and if insulin is more and glucose in the blood is less by mistake, hypoglycemia is precipitated. What happens to these patients? When brain has less glucose, sympathetic overflow, these patients develop sweating, a strange look which their relatives become very familiar. They develop some anxious and some strange type of looks, tremors and palpitation. Is that right? These are the warning signs of diabetic patient on insulin dependence. And what should we do? We should give them a lump of sugar to abort hypoglycemia. But liver also help a lot, because when due to hypoglycemia there is severe sympathetic overflow, epinephrine goes to liver, stimulate the beta 2 receptors, and beta 2 mediated, glycogenolysis occur and glucose come into blood, so that hypoglycemia does not become more worse. Am I clear? You are not clear about it. You are clear? Yes, you are clear about it, that patients who are insulin dependent diabetics, they have high risk of hypoglycemic attack. During the hypoglycemic attack, they develop anxious look, palpitations, tremors and sweating, right? All these sympathetic overflow feature. With that, epinephrine act on the liver and releases glucose from there, so that hypoglycemia does not get worse. Am I clear? Now you imagine patient who is diabetic, insulin dependent, at the top he has some ischemic heart disease or some problem which is very common in diabetic patient, and you are the wise doctor to put him on propranolol. You have to be very careful. You know why? If insulin dependent diabetic patient is on the beta blocker, especially propranolol, whenever he will develop hypoglycemia, he will not develop warning sign, because he will not develop anxiety because beta 1 receptors are blocked. He will not develop palpitation because beta 1 receptors are blocked. He will not develop tremors because beta 2 receptors are blocked. So such patient who is insulin dependent diabetic patient and you are keeping him also on the propranolol, whenever they undergo hypoglycemic episodes, they don't develop warning sign, they don't know they are having hypoglycemia. At the top, you fail the internal glucose provision mechanism. Propranolol also blocks this receptor. So endogenous release of glucose from liver is also blocked. So they have a risk of undergoing life-threatening hypoglycemic episode. So what did I say? That patient who are diabetic and insulin dependent diabetic, if you give them drugs like propranolol, they will not develop the warning signs of hypoglycemia. So they will not take sugar from outside, and unfortunately these drugs will also block the hepatocyte activity to release the glucose, and endogenous release of glucose from the liver is also not there, and they have a high tendency to undergo life-threatening hypoglycemia. What is the message here? That propranolol drug should be contraindicated in patients on insulin dependent diabetes, because these are very, very important things. If you do these mistakes, you give propranolol to a person with asthma or with the Raynaud's disease or a patient with insulin dependent diabetes, I tell you surely you will have a lot of patients suing you. They will get one asthmatic attack, they will get it managed, but you will not be able to manage those millions of dollars for them, right? And next time, you know, insurance company will be very much wary of you, right? So this is all clinically relevant, that beta 2 mediated drugs are good and bad. Beta 2 stimulant again are used as bronchodilator. Beta 2 stimulant are used as tocolytic drugs. Is that right? But at the same time, you must know that yes, beta 2 blocker can precipitate asthma. Beta 2 blockers can worsen the Raynaud's disease. Beta 2 blocker can worsen the hypoglycemia in patient with diabetes mellitus, which is insulin dependent, right? Then one more thing about this, about the beta 2. There is something about, we should talk about tremors. I told you in last video lectures that, you know, there are intrafusal muscle fibers which are having beta 2 receptors, and beta 2 receptor, right, when they are functioning well on the muscles, beta 2 receptors, when they are functioning well, right, they help the muscles to keep their tone properly. For example, if I am keeping my hand outstretched without tremors, one of the reason is that my intrafusal muscle fibers are working well. But whenever I get anxious, I will develop tremors, because during anxiety, epinephrine will come and overstimulate the beta 2 receptors on skeletal muscle intrafusal fiber. So whenever beta 2 receptors on skeletal muscle fibers are overstimulated, you will develop tremors. Now what is the importance of this? Yes, there is. You give beta 2 stimulant for bronchodilation. One of the side effects is tremor. Is that right? One of the side effects is tremor. Now come on another thing. If someone has undue tremors, there are people who have essential tremor. Essential tremors mean they have tremors essentially all the time. There may not be any clear-cut reason why they have tremors, but they do have tremors. So what will do? They can be treated by propranolol. You can block the beta 2 receptors and tremors will be subsided. Am I clear? So when you will become doctor soon and you will be playing with these drugs, what is the difference in average doctor and a great doctor? The difference is how you use your tools, how wisely or clumsily you use your tools. Your tools are drugs, not illicit drugs. These drugs, right? So let's have a break here. Today we are going to talk about that when adrenergic receptors are stimulated, how they induce intracellular signals, right? What are the molecular basis of adrenergic receptors function, right? So let's take different tissues. Let's suppose here is your central nervous system, right? Preganglionic neuron and then postganglionic neuron, releasing norepinephrine here and here, here and here. Let's suppose these are the nerve endings, and from here it is releasing norepinephrine. Now we have to see how norepinephrine work on the adrenergic receptors. I will put one model here. I will explain in this diagram first how the alpha 1 adrenergic receptors work, right? Alpha 1 adrenergic receptors work. So this is a nerve ending which is going to release, yes, norepinephrine, right? Now, once norepinephrine is released, it will bind with the adrenergic receptors. All the adrenergic receptors are belonging to the family of 7-pass receptors, right? Why we call them 7-pass receptors? Because these receptors are peptide chain, and this peptide chain passes through the cell membrane 7 times. 1, 2, 3, 4, 5, 6 and 7. Now this pocket where norepinephrine binds, right? This pocket of the peptide chain, this red peptide chain is the adrenergic receptor. Let's suppose that this is alpha 1 adrenergic receptor, right? Now alpha 1 adrenergic receptor, like other adrenergic receptors, it is a 7-pass receptor. We also call it serpentine receptor. Serpentine means snake-like receptor, right? And intracellularly, these receptors couple with G proteins. So third name for such receptor is G protein coupled receptor. So what we have to remember that all adrenergic receptors are, yes, they have 3 names. They can be called 7-pass receptors because these receptors pass through the membrane 7 times. 7-pass receptors, they can also be called, yes, serpentine receptors, right, because they are like snake. And then they can also be called G proteins, yes, coupled receptors. Even receptors are sexy, you know. G protein coupled receptors, right? Now, alpha 1 adrenergic receptor, like other receptors, they must have one extracellular domain where norepinephrine binds. So norepinephrine binds over here, right? And this point where norepinephrine binds, this is called ligand binding domain. And this intracellular part of the receptor, this is called effector domain. This is called effector domain. Now this effector domain, in case of alpha 1 adrenergic receptor, when, right, effector domain become activated when norepinephrine bind with the receptor, and this activated effector domain will stimulate G protein, right? Now which G protein it stimulates? Which G protein it stimulates? GQ. It stimulates the GQ. G proteins are primarily, yes, G proteins are primarily primeric proteins. They have alpha component, they are having beta component, and they are having gamma component, right? What really happens when this receptor is stimulated by epinephrine or norepinephrine, it will stimulate the alpha component of the G protein. And this G protein is called, yes, this is called GQ, and this alpha is called alpha Q. Now as soon as the receptor activate the alpha component of the G protein, alpha component which was previously binding G DP, it loses the GDP and binds GTP. GTP is high energy molecule, but it binds with the GQ alpha component, then alpha component dissociate with beta and gamma, right? Alpha component dissociate from beta and gamma. This dissociated alpha component, this is now alpha Q, and it is loaded with GTP, and now it is fully active, and this activated alpha component, and of course your friends beta and gamma have been dissociated. Beta and gamma are dissociated from this trimeric complex. Now alpha component will bind with, yes, there is an enzyme here. What is the name of this enzyme? Adenylyl cyclase, and this enzyme is very happy because you remember its name. Very good, right? So everyone is happy when you remember their name, including the enzyme. So adenylyl cyclase is the effector molecule on which, we are wrong. We are dead wrong, because it is alpha stimulatory which bind with adenylyl cyclase. Enzyme is happy because you are fooled. Yeah, GQ does not bind with adenylyl cyclase, rather GQ bind with a different enzyme, and that enzyme is called, yes, who will tell me the name of that enzyme? Yeah, this is the name of that enzyme. Let me tell you. Yeah, this enzyme can attack the cell membrane. This enzyme can attack the cell membrane. When this enzyme is activated, what is the name of this enzyme? Phospholipase C. So actually when GQ is stimulated, the alpha component of GQ stimulates the phospholipase C. And when phospholipase C is activated, this enzyme attacks the lipids in the cell membrane, right? This will attack the lipids in the cell membrane, a very special lipid which is in the cell membrane. This is called, yes, this lipid is called phosphatidyl inositol diphosphate. What is this lipid? Phosphatidyl inositol diphosphate. And this lipid will be attacked by the phospholipase C. When phospholipase C will attack the phosphatidyl inositol diphosphate, this will break down into two components. Right, it will break down into two components. One is inositol, yes, triphosphate, IP3. Other is diacyl glycerol. Then you must be knowing that inositol triphosphate actually act on intracellular stores of calcium. Within the cell, calcium is stored in endoplasmic reticulum, right? So calcium is stored well in endoplasmic reticulum, and here is a calcium transporter, right? And calcium is well stored. What is this? Endoplasmic reticulum, which is very rich in calcium. And what really happens, that IP3 will stimulate this pump. IP3 will stimulate this pump. When this pump is stimulated by IP3 or exchanger is stimulated, calcium will come out, and intracytosolic calcium levels will go up. And this calcium will bind with special type of kinases, right? Calcium will bind with colmodulin. You know the protein called colmodulin, right? And this protein to which calcium is binding, that is called calmodulin kinases. This protein is called calmodulin kinase. Right? Calcium will bind with calmodulin kinase protein. Right? Now, if you really want to know the steps, calcium will bind with calmodulin, and calcium calmodulin complex will activate certain kinases which are called CAM kinases. Now, once calcium calmodulin kinases or CAM kinases are activated, this group of enzymes will phosphorylate target protein. For example, one example of target protein in smooth muscle is, yes, you know, alpha 1 adrenergic receptor produce smooth muscle contraction. You remember that? Very good. So, how it will do? Calcium calmodulin will phosphorylate light chain kinases. There is an enzyme called, yes, light chain kinases, right? And when these light chain kinases are acted upon by calcium CAM kinases, then light chain kinases are phosphorylated. They become active. They become phosphorylated because kinase enzyme add phosphate to light chain kinases. How? They take the ATP and break the ATP into ADP, and phosphate is added to this. When light chain kinases are phosphorylated, who will tell me the next step? They will phosphorylate. They will phosphorylate myosin light chains. They will lead to phosphorylation of myosin light chains phosphorylated. When they become phosphorylated, right, the phosphorylated myosin light chains can participate in actin-myosin interaction. What will happen? Myosin light chains which are phosphorylated, they can participate in actin-myosin interaction. And this actin-myosin interaction will lead to, yes, smooth muscle contraction. So, this is one example how alpha 1 adrenergic receptors work. That alpha 1 adrenergic receptors, once they are binding with the ligand, they stimulate the GQ protein. The alpha component of GQ stimulate phospholipase C enzymes which break down the intramembranous phosphatidyl inositol diphosphate into IP3 and diacylglycerol. What IP3 is doing? IP3 can act on certain calcium exchangers on the endoplasmic reticulum and release the sequestered and calcium right from the endoplasmic reticulum into cytosol. Calcium will bind with the calmodulin and calcium calmodulin kinases will be activated, which will phosphorylate target protein. In smooth muscle, target protein is light chain kinases. When light chain kinases become phosphorylated, they phosphorylate myosin light chains. When myosin light chains are phosphorylated, yes, now they are very happily interacting with the actin. So, actin-myosin interaction start and smooth muscle will contract. Am I clear? Secondly, don't forget this DAG, diacylglycerol. Diacylglycerol is another second mediator produced by phosphatidyl inositol diphosphate, and diacylglycerol can activate. Who will tell me? Diacylglycerol can activate? Yes, please. Another kinase. What is that? Protein. Yes, protein kinase C. Right? So, protein kinase C will be phosphorylated. And when protein kinase C is phosphorylated, right, or activated, diacylglycerol activate. Listen again. Diacylglycerol actually, let me repeat it again. diacylglycerol will act on protein kinase C, and protein kinase C will become, yes, C will become activated. No, please correct, it is not phosphorylated, it becomes simply activated. When protein kinase C is activated in the presence of diacylglycerol, then protein kinase C can phosphorylate certain target proteins, right? Target proteins phosphorylated. So what did we really learn? We learned that whenever norepinephrine or epinephrine or any other compound which is having agonist action on alpha-1 adrenergic receptor, right, that will lead to activation of intracellular GQ protein, activation of phospholipase C, increase intracellular level of IP3 and diacylglycerol, and IP3 will increase intracytosolic calcium levels. Calcium will bind with calcium calmodulin kinases, and diacylglycerol will bind with protein kinase C. When both of these kinases are activated, they will phosphorylate the target proteins, and phosphorylated target proteins will alter the function of the cell. Am I clear? Any problem here? So this was how alpha-1 adrenergic receptors work. If someone asks a very simple question, that when alpha-1 adrenergic receptors are stimulated, which intracellular second messenger's concentration is increased? Then Dr. Nikita will answer, only she will answer, which intracellular second messenger level will increase? What is the second messenger here? Yes? Okay, IP3 and diacylglycerol, but more importantly calcium. Is that right? Intracellular calcium will increase, right? Now we come to action of, we have studied the action of alpha-1 adrenergic receptor. Now we will study the action of alpha, yes, 2 adrenergic receptor, how alpha-2 adrenergic receptors work, right? Let's suppose this is alpha-2 adrenergic receptor. Again you can find alpha-2 adrenergic receptor is also 7-pass receptor, or other name is serpentine receptor, or it is G protein coupled receptor. And whenever norepinephrine or epinephrine binds here and alpha-2 adrenergic receptor is stimulated, intracellularly it will stimulate not GQ. Alpha-1 was coupled with GQ. Alpha-2 receptor is not coupled with GQ, it is coupled with, yes please, G inhibitory. This is coupled with G inhibitory protein, and G inhibitory protein has alpha inhibitory, and with that it has beta, and I think I should change the color so that you don't get confused, right? So G inhibitory has alpha inhibitory, with that it is having, yes, beta inhibitory and gamma inhibitory. So whenever alpha-2 receptor is stimulated, alpha inhibitory component of the G protein will lose the, yes, GDP and acquire the GTP, and now it will become energized and it will dissociate from its friends, right? Alpha inhibitory, which is energized, now it is activated, right? Because it is loaded with, yes, GTP. And of course, when alpha inhibitory will dissociate from beta and gamma, as alpha inhibitory has separated, in the same way beta gamma units will be also separated, beta gamma inhibitory units. Then what will happen, that alpha inhibitory will interact with your friend, yes, you remember now, adenylyl cyclase, and now, yeah, what will happen to adenylyl cyclase? It will bind to this component of the adenylyl cyclase, and whenever adenylyl cyclase has 2 domains, at one domain alpha inhibitory bind, it has another domain, and with this domain, this is a different domain. With this domain, alpha stimulatory bind. So alpha inhibitory binds to this domain, and whenever alpha inhibitory bind, it will lead to inhibition of action of adenylyl cyclase. And when adenylyl cyclase is inhibited, then ATP cannot be converted into cyclic AMP. So G inhibitory or alpha inhibitory component of G inhibitory inhibit adenylyl cyclase. So conversion of ATP into cyclic AMP is reduced. When there is reduced cyclic AMP, so of course then there is reduced cyclic AMP activate, yes, protein kinase A. So there is reduced activation of protein kinase A. Then protein kinase normally phosphorylate target protein. But now because protein kinase A is not stimulated because cyclic AMP levels are less intracellularly, so protein kinase A dependent intracellular activities are reduced. So what should I write? When protein kinase A is not activated, then phosphorylation of protein kinase A proteins don't occur. And we say that there is reduced activity of protein kinase A dependent, yes, intracellular functions. For example, if in this cell there was an enzyme which was acted upon by protein kinase A, and when that enzyme was getting phosphorylated, a metabolic pathway was run. But when alpha 2 receptor is stimulated, G inhibitory is activated, and activated G inhibitory inhibit adenylyl cyclase, cyclic AMP level become less, protein kinase A activity become less, then that enzyme will not be phosphorylated and that enzyme dependent metabolic pathway will be inhibited. Am I clear? Secondly, a very important factor which you must know is beta inhibitory and gamma inhibitory component. Once they dissociate from alpha inhibitory, they can bind with the potassium channels. They are special potassium channels, and these potassium channels have intracellular component where beta inhibitory and gamma inhibitory can bind. So this beta and gamma inhibitory bind with the, what is this? Potassium channel. And as you know, the potassium concentration intracellularly is high. So naturally potassium will start moving from intracellular compartment to extracellular compartment. So what really happened, beta gamma unit of G inhibitory increase potassium efflux. So when the cell is losing the potassium, naturally what will happen to this situation? Yes, cell will become electrically more negative because cell is losing positive charges. So we can say if this cell was having resting membrane potential of suppose minus 70 millivolt, but once potassium is lost, then resting membrane potential will become more negative because positive charges are lost. So it will become minus suppose 90 millivolt. So what really happens, the stimulation of alpha 2 adrenergic receptor, right, which when it activates the G inhibitory, activated beta and gamma units of G inhibitory activate the potassium channels and let the potassium be lost from the cells, and when intracellular potassium is lost outside, so resting membrane potential become more electronegative. It means cell become more polarized towards the negative side, or we simply say cells become hyperpolarized and they become electrically inhibited. Am I clear to everyone? Another point, this is what very few very good students know only, that alpha adrenergic receptors have one more function. This is alpha 2 adrenergic receptor. When ligand binds with it, not only these receptors activate G inhibitory, they also activate a very special type of G which is called G naught, alpha naught and beta gamma units. This is a different type of G protein. This is called G naught. You must be knowing GQ, you must be knowing G inhibitory, we will study about G stimulatory, and this is a different which is called G naught. Actually alpha 2 adrenergic receptors can stimulate the G naught also, and when G naught is stimulated, of course alpha component will lose the GDP and acquire the GTP, and alpha component become activated. And when alpha component becomes activated, then alpha naught loaded with, yes, GTP, right? This binds with the calcium channels. It binds with the, yes, which channels? Calcium channels. And when this will, alpha naught will bind with the calcium channel, it will inhibit the calcium channel. So calcium influx will stop. Calcium influx will stop. This is what happens in the presynaptic nerve endings. If you remember that in the very early lectures of adrenergic system, if this is one neuron and this neuron is releasing norepinephrine here, right? And this is your target tissue. I told you norepinephrine work on presynaptic membrane, right? Through which receptors? Through, yes, alpha 2 adrenergic receptor. And I mentioned that when norepinephrine act on presynaptic membrane, inhibit the nerve ending functions. How it inhibit? Number one, it will, when G inhibitory is stimulated, activated, it activates the potassium channels. And when this nerve ending will lose the potassium, it will become hyperpolarized, it become very negative. So this will be difficult to stimulate this nerve ending. This is one change. Secondly, G naught will block the calcium influx, and when calcium influx is blocked to this nerve ending, the exocytosis of the neurotransmitter release will be less. Thirdly, G inhibitory, right, will inhibit adenylyl cyclase and intracellular protein kinases, and at this point will be inhibited, and they will inhibit the enzymes and transporters which are concerned with synthesis and storage of norepinephrine. So these are multiple mechanisms how presynaptic alpha 2 adrenergic receptors inhibit the presynaptic membrane. Is that right? No problem up to this. Now we come to the, we have learned what are the signaling mechanism of alpha 1 adrenergic receptor. We have learned what are the signaling mechanisms in alpha or molecular mechanism in alpha 2 adrenergic receptors, and now we will talk about what are the molecular basis of signaling mechanism of beta 1 adrenergic receptors and beta 2 adrenergic receptors and beta 3 adrenergic receptors. Again, there is a question. If, let's have a break. Now we will talk about the intracellular signaling mechanism for beta receptors, right? Beta 1, beta 2 and beta 3. The good news is that the intracellular signaling mechanism for beta 1, beta 2 and beta 3 are same, right? So let's study the beta 1 intracellular mechanism. When beta 1 adrenergic receptor is stimulated, let's suppose this is beta 1 adrenergic receptor, right? And if epinephrine or norepinephrine, right, with beta 1, let's suppose epinephrine binds here, right? Epinephrine. This is the beta 1 adrenergic receptor. You remember alpha 1 adrenergic receptor was coupled with GQ. Alpha 2 adrenergic receptor was coupled with G inhibitory. But beta 1 adrenergic receptor is coupled with G stimulatory, right? It is coupled with G stimulatory protein. So let's suppose this is alpha component of alpha stimulatory, this is beta and gamma stimulatory, right? When epinephrine bind with beta 1 adrenergic receptor, it intracellularly stimulate the G stimulatory. Which component of the G stimulatory? Alpha component of the G stimulatory, and then of course alpha component on stimulation loses GDP and acquires GTP. right? And this alpha component also dissociate from beta and gamma. This alpha stimulatory component which is loaded with GTP, right? It dissociates from beta and gamma component, right? And it interact with, yes please, with adenylyl cyclase. If you remember, adenylyl cyclase has 2 points. There was one point where G inhibitory could bind, other point where alpha component of G stimulatory could bind. And when, right, this adenylyl cyclase is stimulated by alpha stimulatory, right, then what really happens? That this will stimulate the activity of adrenylyl cyclase, and adrenylyl cyclase will start converting ATP into cyclic AMP. So there is raised intracellular cyclic AMP level. Again, when beta 1 adrenergic receptors are stimulated, they are coupled with intracellular G stimulatory protein, and G stimulatory protein alpha component stimulate adenylyl cyclase, which convert more ATP into more cyclic AMP. And this cyclic AMP is the second messenger of this system. This second messenger molecule will stimulate, yes, cyclic AMP molecule will stimulate, yeah, what is this? Protein kinase A, right? And this protein kinase A will start phosphorylating the target protein. It will start phosphorylating target proteins, right? Whatever target protein is there, right, that protein will be phosphorylated. Now, when proteins get phosphorylated, their functions are altered. In this way, a target cell's functions will be altered. As you know, now let me give you a few examples. Beta 1 receptors, when they are stimulated, there is cardiac stimulation, right? There is cardiac stimulation. There is increased heart rate. There is increased contractility. Now, how it really happens? It happens by two ways. The one of the target protein may be calcium channel. Here is the calcium channel. And if protein kinase A phosphorylate the calcium channel, and when calcium channel get phosphorylated, it work more efficiently, and there will be more calcium influx. There will be more calcium influx, and calcium dependent intracellular mechanisms will be accelerated. For example, when calcium will, again, protein kinase A, when it is stimulated, it can phosphorylate calcium channels. Suppose these calcium channels are present in SA node, then there will be more calcium influx in SA node. And you know that in SA node and AV node, action potential is dependent on calcium, right? In the same way, calcium influx will occur in atrial and myocardial cells also. And myocardial cells, contractility is also dependent on calcium, so there will be positive inotropic action, right? So, but one thing which many students don't know, that alpha stimulatory can directly, now this is a very important point, alpha stimulatory can directly stimulate, alpha stimulatory can directly bind with the calcium channels and stimulate it directly also, right? So in this way we can say that when G stimulatory proteins are stimulated, right, by the stimulation of beta 1 receptors, right, intracellular cyclic AMP level increase, protein kinase A activity increase, and protein kinase A will phosphorylate target proteins and bring changes in intracellular function. Plus, what we have to talk about, that alpha stimulatory can directly bind with the calcium channels and increase the activity of calcium channels, so calcium influx becomes more, and calcium dependent electrical activity in the myocardium and calcium dependent contractile activity of the myocardium will be amplified. Am I clear? As I told you, the good news is that beta 1 receptors, beta 2 adrenergic receptors and beta 3 adrenergic receptors, all of them are coupled with intracellular G proteins, and in all of them there is increased intracellular cyclic AMP level, right? So the intracellular signaling mechanism for beta 1 and beta 2 and beta 3 is the same, right? Now let's do a little review and then we'll continue further. Let me put here adrenergic receptors, right? Already you know adrenergic receptors are divided into alpha and yes, beta. Alpha are divided into alpha 1 adrenergic receptors, alpha 2 adrenergic receptors, beta are divided into beta 1 adrenergic receptors, beta 2 adrenergic receptors, and beta 3 adrenergic receptors. Now, these adrenergic receptors, which is alpha 1 adrenergic receptors, they are coupled intracellularly with which type of G protein? Just please. GQ. And what is the second messenger system? Just please. IP3 diethyl glycerol, leading to and eventually leading to increased intracellular calcium level. Excellent. Now we'll talk about alpha 2 adrenergic receptors, right? Alpha 2 adrenergic receptors, they are intracellularly coupled with which G protein? G inhibitory, and that will lead to, yes please, decreased, that will lead to actually three types of activity. G inhibitory, when it is stimulated, number 1, yes, decreased intracellular cyclic AMP. Number 2, there is increased potassium efflux, and number 3, there is decreased, decreased calcium influx. Am I clear? No problem. Now we come to beta 1 adrenergic receptors. Beta 1 adrenergic receptors are intracellularly coupled with, yes please, G stimulatory. And what will be the result? In the cell, there is, yes, increased intracellular, yes, cyclic AMP level. Plus, it has one more thing. G stimulatory has two activities. One is this, and other is, yes, increased calcium influx. Increased calcium influx. And then there is the good news that beta 2 receptor mechanism and beta 3 receptor mechanism is the same as beta 1. Any question up to this? There is no question. That's it. Yes.
Everyone of these receptors, which is the one that the beta and you know that it stimulates the alpha portions?
Yeah.
And then the beta and the gamma portion, which is the one that stimulates the potassium channel?
Which component stimulates the potassium channel? Potassium channel is stimulated by beta gamma unit of the G inhibitory, right? Okay. And calcium channels are blocked by the G naught, right? And here calcium channels are opened by the G stimulatory directly, alpha stimulatory, and also by the phosphorylation of the calcium channels. Any more question? No. Okay, so now we go to the next area. Next area is really very important and applies to lot of areas in pharmacology and endocrinology and neurotransmissions in central nervous system and peripheral nervous system. Right, now we will talk about the concepts of desensitization. How the receptors and signaling mechanisms can be desensitized. First we talk about what is the concept of desensitization. Actually, when a specific agonist is continuously stimulating a receptor and signaling mechanism, then with the time receptor and signaling mechanism become less efficient. It becomes less efficient and response to the same concentration of the agonist progressively decreases, right? Let me give you first example of desensitization from the practical life, romantic life, from marital life. It's very common that before the marriage, men are very super sensitive to the would-be wife. But after the marriage, men start getting desensitized to their wife. For example, if wife is very demanding, right? She is too much demanding and too much interaction. You know, whenever there's excessive interaction of anything, biological system may undergo desensitization, right? Now, if wife is too much stimulatory, or you can say demanding on the husband, or interacting too much, after some time, to prevent the overstimulation, maybe the person put cotton in his ears so that he doesn't listen much, right? This is early stage of desensitization, that she is talking but he doesn't listen. He is still in the home but doesn't listen. But if she still keep on having agonist action, then what he will do? He will run out of the home. He will spend more time out of the home. He will spend time where his wife cannot approach and do some agonist activity. Is that right? But if still, whenever he comes back sometimes, she's too much agonist activity, what he will do? Most probably he will commit suicide. This is what exactly happens with the receptor and molecular system. That when receptors are too much stimulated, first they put the cotton plugs. What are cotton plugs? There are no cotton in the cell. The cotton plug for the receptor is phosphorylation, phosphates. When receptors are overstimulated, they get phosphorylated and they become less sensitive to agonist. If still stimulation is too much, the phosphorylated receptor go intracellular. We call it sequestration. They run away from the cell surface to avoid the agonist activity, right? And if they turn back to the membrane and again there's too much stimulation, then they go inside the cell and get catabolized, committing suicide. Let me explain step by step. Let's suppose that here is a cell and here this cell has adrenergic receptor. Let's suppose this is beta 1 adrenergic receptor, and the same cell, let's suppose, has one more receptor which is called alpha 2 adrenergic receptor. All of you know that beta 1 adrenergic receptor stimulate G stimulatory, alpha component of G stimulatory, and alpha 2 adrenergic receptor stimulate intracellularly, yes, alpha component of G inhibitory. And then, as you happen to be very intelligent, so you must be knowing that if here is your friend adenylyl cyclase, right, here G inhibitory can interact and here G stimulatory can interact, right? So when G stimulatory or alpha stimulatory interact here, this stimulate adenylyl cyclase, right? That will lead to stimulation of adenylyl cyclase activity. But if G inhibitory is activated through alpha 2 adrenergic receptors, then what will happen? That G inhibitory will engage here and G inhibitory will lead to inhibition of adenylyl cyclase activity. And what is the activity of adenylyl cyclase? Adenylyl cyclase is responsible to convert, yes, ATP into cyclic AMP, and cyclic AMP, yes, stimulates protein kinase A. It stimulates protein kinase A. Is that right? Now let's suppose that if we are stimulating beta 1 adrenergic receptor strongly, there are a lot of epinephrine molecules and there is strong stimulation of beta 1 adrenergic receptors. Now, when these receptors are stimulated, right, their intracellular component undergo a change, and this alteration in intracellular component of the receptor has two effects. One effect is it will stimulate G stimulatory. Other effect is that it will open a very special area, and with this area there is an enzyme inside. It will activate here. The enzyme is like a, I don't know how to make a dog. Do you know how to make a dog? Okay, let's suppose this is some dog. I don't know, it's unusual dog, I think. Right. This is barking. B-A-R-K. This is an enzyme present within the cell all the time. All those cells which have beta 1 adrenergic receptors. Right. This enzyme is barking. Why? Because its name is beta adrenergic receptor kinase. What is the name of this enzyme? Yes. Beta adrenergic, yes, receptor kinase. It means that it can do kinase activity with beta adrenergic receptor. Right? This enzyme can do kinase activity on beta adrenergic receptor. But when it will do kinase activity? It will do kinase activity to beta adrenergic receptor only when beta adrenergic receptor is loaded with the agonist. Right? So whenever beta adrenergic receptor are loaded with the agonist, they are bound with the agonist, they are bound with, suppose, epinephrine, right? This alters an intracellular domain, and this intracellular part of the molecule becomes available to this doggy enzyme. And this doggy enzyme, which is called beta adrenergic receptor kinase, will act on that point. And what it will do? It will phosphorylate. It will phosphorylate some part of the receptor. And when this part of the receptor is phosphorylated, when this part of the receptor is, yes, what is happening to this part of the receptor? It is getting phosphorylated, then receptor become resistant to the action of the agonist. So what has happened? We can say that receptor has, yes, what has happened here? The receptor has been phosphorylated, and this phosphorylated receptor will undergo further change. When this receptor becomes phosphorylated, then there is another protein present in. This protein will go and bind with the phosphorylated. Okay, I will make this protein like that, right? This protein will go and bind with phosphorylated receptor, right? And when this protein will bind with phosphorylated receptor, when this protein has bound the phosphorylated receptor, do you think now G stimulatory can bind here? Attention please, let me review what happened. Epinephrine came, stimulated the receptor, receptor stimulated the G protein, and of course alpha component of G protein went to stimulate the adenylyl cyclase. Is that clear? Meanwhile, receptor got phosphorylated by the beta adrenergic receptor kinase. When receptor got phosphorylated, then another protein went and bind with the phosphorylated receptor. And when this protein bind with the phosphorylated receptor, can alpha component again bind with this? No. It means presence of this protein will arrest the signaling mechanism. Are you understanding? Presence of this protein will arrest the signaling mechanism. So this protein is very appropriately called beta arrestin. What is the name of this protein? This is called beta arrestin, right? And once receptor get phosphorylated by beta adrenergic receptor kinase and then receptor get loaded with beta arrestin, do you think then agonist may be still binding here, but can signals go forward? No. So it means receptor system is getting desensitized to the presence of agonist. That receptor is having the agonist but not passing the signals forward. So what will happen to the same dose and same concentration of the agonist, the response of the cell and tissue will be less. So we'll say receptors is desensitized, or we can say cells are desensitized, or we can say tissue is desensitized, or even we can say patient is desensitized to this particular drug. Am I right? This type of receptor phosphorylation and binding of the arrestin with the receptor produces desensitization within few seconds. Is that right? So we call it rapid desensitization. This mechanism is rapid, yes please, rapid desensitization. Is that right? If walking, again go back to that example, when wife is talking too much to the husband, he is worried about his office matter but she is more worried about her shopping, and she is talking and talking and talking, what will happen? First, husband will get phosphorylated and maybe some other woman come and bind there, and even arrestin activity may occur. So be aware, both parties, right? It's dangerous for both. Am I right? And this type of desensitization can occur rapidly. Is that right? Now, but remember, if we remove the agonist for a short time, wife become less demanding and less about the shopping, right? He will turn back, most probably. If she in time, she withdraws. Same is true that if this agonist for a short time is kept away, right? The arrestin will go away, dephosphorylation will occur, and receptor will become what? Again, sensitive. Am I right? This is one example. Then there is another type of desensitization. Let me show you here. This type of desensitization is called, yes, homologous. This is an example of homologous desensitization. Desensitization. What is meant by the homologous desensitization? Homologous desensitization means that agonists bind with one receptor and the same receptor becomes desensitized. Is that right? Now you imagine another thing. Listen carefully first to the example. There are few couples living together in an apartment building, and one wife is very hard on her husband, right? Always demanding for shopping, I want this, and shouting, and everyone is listening. So not only husband of that wife will become desensitized, the risk is that other husbands in the building may also get desensitized. That wives are like that, and they may not listen to their wife, other husbands may not listen to their genuine demands of their wife. That is called heterologous desensitization. Are you understanding me? Really? Right? So, again, if my wife is shouting to me a lot, and if I get desensitized by phosphorylation and arrestin, what is this? Homologous desensitization. But if other husbands see what's happening with me, and they learn something, and they also become desensitized to their wife, it means too much agonist activity on me lead to my homologous desensitization, and other receptors, other husbands, heterologous desensitization. Let me tell you the exact molecular mechanism of heterologous desensitization. Let's suppose, this receptor system is giving signal, then what will happen? Adenylyl cyclase will be activated, right? And then protein kinase A will be stimulated. Protein kinase A does many functions. You remember it does phosphorylation of target proteins, and target proteins will undergo phosphorylation of target proteins. But you will be surprised to know that protein kinase A may also do phosphorylation, may do the phosphorylation of receptor which stimulated, as well as it may do phosphorylation of some other receptors which are working through the same signaling mechanism. You are getting it? And I told you when receptors are getting phosphorylated, they are becoming less efficient. So what was happening? That this receptor was having too much agonist activity, stimulating its G-stimulatory, stimulating adenylyl cyclase, getting more cyclic AMP, increased activity of protein kinase A. And this protein kinase A will phosphorylate many proteins, including some receptors which are acting through the same molecular mechanisms. Is that right? So if this receptor, which is alpha 2 adrenergic receptor, that is phosphorylated, it means that sensitivity of this receptor and response of this receptor mechanism to the agonist will be also reduced. This type of receptor desensitization is called heterologous desensitization. What is this called? Heterologous desensitization of receptors. Is that right? Remember, in homologous desensitization, phosphorylation is followed by attachment of arrestin. But in heterologous desensitization, there is simple phosphorylation. But that is also enough to bring some decreased response of the receptor mechanism. Am I right? Any question up to this? So this is a rapid type of desensitization. Then there can be relatively slow mechanisms of desensitization. As I told you, don't forget. Let's go to our basic examples of desensitization. Wife demanding husband too much. What will happen? That husband does not listen. And even he gets some arrestin, some beautiful other lady. Right? What is that? Rapid homologous desensitization. But if that husband is suffering, listening to wife, doing a lot of shopping and suffering financially, right, too much agonist activity, then other husband take a lesson from him and they don't listen to their wives, unfortunately. What is that? Heterologous desensitization. But if that wife is really very persistent, she believes in perseverance, so then what will happen? She disturbs him too much agonist activity, what will happen? He will run away from home. He will run away from home and he would like to stay away from his wife. He will like to stay at places where his wife cannot come with the demands and agonist activity. Same thing happens with the receptors also. If they are really too much stimulated, they decide to run away from the cell membrane to inside and hide into cell, like the poor husband. Right? So what really happens that, let me put simple diagrams of these receptors. What are these receptors? Suppose adrenergic receptors. All these receptors are strongly stimulated. When these are strongly stimulated, I told you they will get phosphorylated. If receptors remain phosphorylated repeatedly, then receptors bind with some special intracellular proteins. These intracellular proteins are called calatherins. What are the name of this protein? These proteins are called calatherins. These phosphorylated receptor, especially with arrestin, they bind with the calatherins, and calatherins are special proteins which pull the membrane inside. They pull the membrane inside. So this piece of the cell membrane loaded with the receptor will go in, right? And receptors are still present over there. You are understanding? And they are still having what? Phosphorylation, you remember? And they are also having their, okay, I will change the color. What was this? Calatherine. So calatherine, we call it, this calatherine coated part of the membrane pulls in. So this is, a vesicle is being formed. After a little time, this will go inside the cell. Now inside the cell, this was calatherine coated pit. Now it has become intracellular vesicle. Receptors have escaped from the cell membrane or cell surface to the intracellular area. Is that right? And they are still phosphorylated. What are they? Phosphorylated and clathrin coated. Then what happened? When receptors have gone in, can epinephrine stimulate these receptors which have gone intracellular? No, because epinephrine cannot go into cell. Because epinephrine molecule is highly polar molecule. It is highly charged molecule. So it cannot go in. So in a way, when receptors have gone in the intracellular vesicle inside the cytoplasm, they are not available to the agonist. So tissue response to that agonist will reduce. Right? These receptors remain in for short time, right? As husband ran away from house, and when he will go away after, for example, for 2-3 days, and then he will remember, he will forget his anger, and he will remember, no, my wife is good, there was a time I used to love, still I can try something, and maybe as it happened, he will come back. Same happens with these receptors. What happened? That they remain inside, sequestered. We say receptors have been sequestered. This process is called sequestration. What is this mechanism called? Sequestration. So we say that not over second, over minutes, many receptors are internalized by the cell and they are sequestered by the cell, and number of receptors transiently available on the membrane are less. But when receptors go in, like that poor husband, right, they again become activated. How? That there are enzymes here which are called phosphatases. They will dephosphorylate it, and they are now again ready to undergo action. Right? And after that, when they become dephosphorylated and they become again fully sensitized, what will happen? You know what will happen? What happened to that husband? He came back. Right? So this vesicle will come to the surface, right? And receptors are again available on the surface. So this was a transient, what was this? A transient desensitization. So listen again. Previously we talked about that receptor was phosphorylated. It was available on the surface but not responding well. That is called rapid desensitization by phosphorylation. In second example we took that when receptors are really stimulated too much, eventually they undergo process of sequestration, right? They go inside the cell and they hide it from the stimulating agent. There they get dephosphorylated and again develop their full sensitivity to the membrane and again recycle on the surface. Is that right? So that, you know, they have come back to the home and again, you know, that wife is there, but unfortunately she has not learned much. She come back with all her demands. Look at her. She's very happy that stupid man is back, right? And now, again too much stimulation. It means this group of receptor will again and again cycle in. Look, it will get phosphorylated, cycle in, sequester, dephosphorylated, and then again re-express. But every time when it is treated with too much stimulation over a long time, over hours, oh my God, you know what will happen to that man? Repeatedly come back, suffer too much, again goes, get emotional energy, come back, again suffer. Eventually he will decide to commit suicide. So same will happen to this receptor business. That eventually with repeated sequestration cycles, they become so heavily phosphorylated, they cannot be dephosphorylated, and then these vesicles take a different pathway. They don't express on the surface again. Man does not come back home. What happened to this man now? Not man, I think we were talking about receptors. These receptors which were initially transiently overstimulated and they were phosphorylated and sequestered, now they will fuse with, what is this? This is endosomes. You know lysosomes. Every cell has lysosome with dangerous enzymes. These are lysosomes with dangerous enzymes. Eventually, these endocytic vesicles loaded with the receptors will fuse with the lysosomes, and very dangerous lysosomal enzymes will attack the receptors, and then receptors will be, yes, receptors will be catabolized. And these receptors which are catabolized, of course, they will not cycle back. And what will happen? The receptor concentration or receptor density on the cell membrane will be reduced for long time. Is that right? This is called down regulation of receptor. This is called down regulation of receptor. Is that right? Now, down regulation of receptor occurs in many ways. One way is the receptors which are already overstimulated, they are internalized and eventually they bind with the lysosomal, their endosome bind with the lysosomes, and then receptors are destroyed. So we can say there is increased catabolism of receptor. What is there? There is increased catabolism of receptors. Receptors have committed suicide. And listen, if many receptors are committed suicide, okay, listen, in your town, if many husbands are committing suicides, do you think young boys will love to marry? It's a good example or a bad example? Marriage rate will go down. This is exactly what happened in the cell also. That when many receptors are committing suicide, they are internalizing and they are undergoing catabolism, the signals go to the nucleus. And in the nucleus, if this is the nucleus, this is the DNA. You know how receptors are made? From the DNA we make? Yes. From the DNA we transcribe RNA. And then RNA come out, bind with the ribosomes, and then peptide chain is made, and this peptide chain convert into receptor. Is that right? This is the normal mechanism. DNA to RNA to DNA transcribed into RNA, and RNA is translated into peptide, and this peptide will appear on the surface as receptor. Normally, small percentage of receptors are going under catabolism and small percentage of new receptors are continuously being made. This is normal physiological receptor turnover mechanism. But when receptors are too much stimulated, the rate of catabolism becomes fast. At the same time, signals go to this all synthetic process, and this synthetic process also get inhibited. Those cells which are overstimulated by an agonist, then messenger RNA, for the formation of those receptors which are overstimulated, that messenger RNA undergoes less concentration. So it means synthetic processes are also down regulated. Is that right? Am I clear? So what really happens, that eventually synthesis of receptors become less, catabolism of receptor becomes more, and number of receptor on the cell membrane become permanently low. Is that right? Whole this process is called, yes please, what is this called? Down regulation of receptors. Down regulation of receptor as means there is permanent, yes, decrease in receptor number by two mechanisms: increased catabolism of receptor plus there is decreased synthesis of receptor. Am I really clear to you? Is that right? So all this is called receptor signaling mechanisms desensitization. Is that right? Again, I will just make it briefly. That when agonists come and overstimulate a receptor, first of all, receptor will undergo phosphorylation and undergo rapid desensitization. Receptor stays there but does not listen. Right? This is the mechanism. Phosphorylation is two types. There is homologous desensitization and there is heterologous desensitization. In homologous desensitization, the receptor which is loaded with the agonist, this receptor exposes the domain, intracellular domain, to be acted upon by the beta adrenergic receptor kinases. This beta adrenergic receptor kinases is a whole family of enzymes, kinases, which are called G protein coupled receptor kinases. This dog belongs to a big family of dogs. all those dogs actually phosphorylate the G protein coupled receptor. So beta adrenergic receptor kinase is the one member of G protein coupled receptors kinases, right? When receptor is loaded, this will phosphorylate that, and then with the phosphorylated receptor, arrestin will bind. After that, when receptor is phosphorylated and bound with the arrestin intracellularly, then G proteins cannot bind with this and receptor cannot give signal, right? This is homologous desensitization. Another example is of desensitization when receptor has given signal and activated an adenylyl cyclase, cyclic AMP has gone up, protein kinase A is stimulated. Stimulated protein kinase A will do many target function, but it may also phosphorylate the same receptor which produce the whole activity, plus it may phosphorylate some other receptors which are also acting through the common, what is this, effector system. And when other receptors are phosphorylated and they become desensitized to their agonist, we say there is heterologous desensitization. Then I told you, if there's too much stimulation, now receptor have to run away, at least transiently. That is an example where phosphorylated receptors, especially with arrestin, bind the clathrins and they make, what is this, endocytic vesicle, and transiently receptor disappear from the membrane to the internal environment and become unavailable to the agonist. But initially when the vesicles are formed, they are internalized, there is sequestration of the receptors, phosphatases will dephosphorylate the receptor, and like a stupid husband, they will come back to the membrane. When they will come back to the membrane, if wife is not intelligent, she will again push more and more agonist activity. If repeatedly sequestration, internalization and recycling, these cycles go many times, eventually a change comes and endocytic vesicle with receptor start fusing with the lysosomal granules, and lysosomal enzyme destroy the receptors, and then receptors number become permanently less. Meanwhile, signals go to the nucleus, the receptors are too much stimulated, we don't need so much receptors there, and what really happens that messenger RNA which is involved in the synthesis of this receptor, that is also reduced. So the net result is over prolonged stimulation that increase catabolism of receptors and decrease synthesis of receptor, and receptor number on the cell membrane become permanently low, and we say that there is down regulation of receptor. So there are three types of desensitization, right? Rapid desensitization by phosphorylation, right? Then there is transient disappearance of receptors, sequestration, and permanently receptors are reduced, yes, down regulation. Am I clear? For sure. Now let me tell you another thing. Have you heard of upregulation of receptors? Have you heard of it? You know the concept, or should I explain? That when a group of receptors are not stimulated on the membrane, they become more sensitive to the agonist. Let me tell you the practical example. For example, a person's wife is very good, but she goes to her parents for 2-3 months and he misses her too much. Then what will happen? He will become less sensitive to her or more sensitive to her? He will become so sensitive, even again he will talk on the telephone very romantic things, but she should stay for enough time there. You are understanding? That is upregulation of husband's emotions, right? But remember, a little distance increases love, but too much distance decreases it. Someone else may come, right? Now let's come back. I don't know, you laugh at that. This is a very important thing, more important than medical science. Anyway, let's come back. So what I'm talking about, receptors can be upregulated also. Let me give you an example here. Let's suppose this is beta 1 receptors, right? Okay, I'll give the example here. Let's suppose this is a cell from the heart. These are beta 1 adrenergic receptor. You are giving the person propranolol for many months and years. For example, I'm a person with hypertension, and you give me propranolol, beta blocker, and there's a very good response and my blood pressure is controlled. So you keep me on propranolol for a long time. Meanwhile, if I get some What is that? Well controlled. If here is propranolol and propranolol is blocking the receptors. If these receptors are blocked, do you think epinephrine can stimulate these receptors? No, epinephrine cannot stimulate these receptors. So there is understimulation of receptor. When receptors are understimulated, none of them will be phosphorylated. None of them will be sequestered. All of them will be on the surface. And nucleus will be getting message. Whenever receptors are activated, a message goes up to the nucleus. That receptor and signaling mechanism is working. But when receptors are blocked by agonist, nucleus loses those signals. So nucleus assumes, the genetic machinery assumes that if there is no signal coming, probably receptors are not there. So they will start expressing receptor associated gene more, and receptor synthesis will increase. Remember, if you overstimulate the receptor, receptor genes underexpress. If you do not stimulate the receptors, genetic operators think probably why there is no signal coming, probably there are less receptor. So genetic operators start synthesizing more receptors. So what will happen? What will happen? Synthesis of receptor will be more, and receptor will become more and more and more and more and more. Membrane become overloaded with the receptors, and you keep on giving propranolol and keep on them blocking them. Is that right? Now receptors are upregulated, but you are keeping them blocked with propranolol. It is a very big clinical significance. If I'm hypertensive patient, you are giving propranolol for a long time, and on my heart beta 1 receptors have been blocked for a long time, then receptors are upregulated. Their concentration on the SA node, AV node and other myocardial tissue become very high. And if due to some doctor who doesn't know these things, one day I go to doctor and I say my hypertension is not being controlled by beta receptor. He checked my hypertension, and with the time, over 5 years, my hypertension is no more controlled by propranolol. And that doctor decided to change my drug, and he abruptly stopped my beta blocker, and all receptors become available for endogenous epinephrine. Heart is super driven by the endogenous epinephrine. Heart rate goes up, contractility goes up, palpitations are there, and if I have some coronary artery disease due to hypertension, myocardial infarction may precipitate, only because doctor did not know that if someone has taken beta blockers for a long time and his receptors will be upregulated, in such cases propranolol should not be stopped abruptly, it should be gradually tapered off. Is that right? So as doctors, even though I was just talking about adrenergic receptor, but in whole pharmacology, you must be clear about the concept of receptors desensitization, sequestration and downregulation, as well as you must be very clear about concepts of receptor upregulation. Today, we are going to discuss the structure activity relationship of sympathomimetic amines. You already know what is sympathomimetic amines. Sympathomimetic amines are those endogenous compounds or drugs which produce activities in the body which mimic the stimulation of sympathetic nervous system. Again, what are sympathomimetic drugs? Sympathomimetic drugs are the group of drugs and the compounds, right, which produce such actions in the body which are normally produced by stimulation of sympathetic nervous system. So these compounds have their actions mimicking the actions of sympathetic stimulation. Now, usually you are not supposed to learn structure and function relationship between most of the drugs, but as far as sympathomimetic drugs are concerned, it's very important for you to understand the relationship between the structure and function of the drug, because if you alter the structure of the drug, the function of the drug on the receptor is altered. Even duration of action of the drug is altered, right? Even the drug absorption and distribution in the body is altered. So let's concentrate on the structure of the drugs, sympathomimetic group and their different altered compound. The primary structure is the parent compound is having a benzene ring or phenyl ring. This is a benzene ring. With this benzene ring, it is having ethyl chain. It is having ethyl chain, and with this ethyl chain, it is having amino end. So this structure is called, this is benzene ring, this is also called phenyl ring, right? And I must tell, this carbon is called alpha carbon and this carbon is called beta carbon. So this is the parent compound from which the sympathomimetic drugs are derived. This is the parent compound. Now, in this parent compound, we can see that to the beta carbon of ethyl chain, there is attachment of phenyl ring. This is phenyl ring as well as benzene ring. So this compound is called beta, because to the beta carbon, beta phenyl, phenyl is the ring, phenyl ethyl amine compound. So this compound or the parent compound is phenyl ethyl amine, right, compound, and this is its phenyl ring, this is its ethyl component of the chain, and here it is amino side chain, right? Now this is the primary structure of all sympathomimetic drugs. How this structure fit into adrenergic receptor to produce its action? Let me draw a cell on which there are many adrenergic receptors. Now, suppose this is a cell and here I put one adrenergic receptor . Now let's suppose this is the hypothetical structure of the adrenergic receptor, and of course all of you know adrenergic receptor is 7-pass receptor. So actually from here, now this is the point where the drug is binding, right? Now because drug is binding here, how this drug fits into this structure, right? Basically this component of the drug, this benzene ring, that is fitting over here, benzene ring, and this component of the drug, which is ethyl group, that has to fit into this area, and in the end you are having here, yes, amino end which will fit here. Now listen carefully. This is how this drug is, primary compound is binding with the receptor. Is that right? Now listen, if this primary structure, the benzene ring, has some side components, then it will fit strongly into the receptor. Can it escape? No. But if, let's suppose, these two compounds are not added on the side of the benzene ring, then drug will bind and bounce back. So it will not bind here strongly. So for a strong binding of the drug on the receptor, we need that there should be some special groups on the sides of this benzene ring. Now what are these two special groups? Because if these two special groups are present on the side of the benzene ring, right, then this will bind here strongly and for longer duration, and it will produce stronger stimulation to the receptor. Now let's see what are these two side special groups. As you know, this is our benzene ring or phenyl ring. Right here it has carbon number 1, carbon number 2, 3, 4, 5 and 6. Right? Now, actually, if we add here hydroxyl groups, right? Then this compound is called, dihydroxybenzene ring. The other name for dihydroxybenzene ring. The other name for dihydroxybenzene ring is, catechol ring. Catechol ring. So it means that if you take this primary compound and you add hydroxyl at carbon number 3 and carbon number 4 of the benzene ring, then you have converted benzene ring into catechol ring, and then this compound will be called catechol ethyl amine, or simply we call it catecholamines. So all those sympathomimetic drugs which are having hydroxylation and carbon number 3 and 4 on the benzene ring with ethyl group and amino end, those are called catecholamines. Now listen carefully. Look at the activity of these two hydroxyls. When these two hydroxyls are present, of course, the catecholamine drug will bind more strongly with the receptor. So action of the drug on the receptor will be increasing, and such sympathomimetic drugs which bind directly with the receptors, adrenergic receptors, and stimulate the adrenergic receptors, such sympathomimetic drugs are called direct acting sympathomimetic drugs. Those sympathomimetic drugs which directly stimulate the adrenergic receptors, they are called direct acting sympathomimetic drugs. Now you can understand, because all catecholamines are having these two hydroxyls, so all of them strongly bind with the adrenergic receptors, so all of them are directly acting sympathomimetic drugs. So these hydroxylation will determine that catecholamines are directly acting, sympathomimetic drugs. Now let me tell you. For example, here is your heart. I don't want your heart to be black, but anyway it's there. There is your heart, and this is sympathetic nerve ending, right? You know that norepinephrine is stored in the vesicles, and from the vesicles, when sympathetic stimulation comes, norepinephrine is released, and then norepinephrine work on its receptor. Is that right? Now listen. Those drugs which directly stimulate the receptors, those drugs which strongly bind with the adrenergic receptors and directly stimulate the receptors, those drugs are called, direct acting sympathomimetic agents or compounds or drugs. Opposite to that, there is another group of drugs which do not bind with the receptors properly, but these drugs are taken up by the sympathetic nerve endings. This is the second group of drugs which do not bind with the receptors well. They don't bind with the receptor well, but they enter into sympathetic nerve endings and go into neurotransmitter vesicles and increase the release of norepinephrine. Of course, such drugs, group number 2, which are going to sympathetic nerve endings and increasing the release of norepinephrine, of course, this increasingly releasing norepinephrine will also act on the receptor and produce sympathomimetic action. But such drugs are said to be indirectly acting sympathomimetic drugs. What are indirectly acting sympathomimetic drugs? Indirectly acting sympathomimetic drugs are those drugs, sympathomimetic drugs, which enter into sympathetic nerve endings and increase the release of endogenous catecholamines. Right? Now, and of course, there is another group, the group number 3, right? And this group number 3 has some activity to bind with the receptor, and they are also taken up into nerve ending. So the drugs which belong to the third group, they to some extent slightly they stimulate the adrenergic receptors directly. Secondly, some of this drug enters into nerve ending and increases the endogenous release of norepinephrine. So this drug is working directly acting as well as indirectly acting sympathomimetic drugs. This is also called mixed action sympathomimetic drugs. We'll go into detail later. So you understand, when I say to you, there's a directly acting sympathomimetic drugs, it means this is a drug which will strongly bind with the adrenergic receptors and stimulate them. And when I say there's indirectly acting sympathomimetic drugs, I'm telling you that this drug is going to sympathetic nerve endings or into adrenal medulla and releasing the endogenous stores of norepinephrine and producing sympathomimetic activity indirectly. And there are some drugs which can bind receptors as well as they can be taken up by the nerve ending. So this produce direct sympathomimetic activity as well as by increasing the release of endogenous sympathomimetic drug, they produce endogenous release of catecholamine. They act as indirectly acting sympathomimetics as well. Such drugs are called mixed acting sympathomimetic drugs. So these are mixed acting sympathomimetic drugs. And here you have mainly working here and not working on the receptor. This is called, yes, indirect acting sympathomimetic drugs. Am I clear? Now come back to this structure. If these two hydroxyls are present, the compound will be catecholamine. Is that right? Any sympathomimetic drug which is having hydroxylation at 3 and 4 carbon of the third and fourth carbon of the benzene ring, such drugs as a group are called catecholamines, right? And of course, which are the members of catecholamines? Catecholamines have, yes, who will tell me the members of catecholamine? Norepinephrine, epinephrine, yes, epinephrine, yes, please, dopamine, and isoproterenol. Now look, these 4 are catecholamines. 3 of them, norepinephrine, epinephrine and dopamine, are endogenous catecholamine, right? They are produced within our body and also they are available as drugs. And isoproterenol is a drug. It is not endogenously produced in our body. But these 4 compounds, norepinephrine, epinephrine, dopamine, isoproterenol, these are having catechol ring in their structure. So they are called catecholamines. And of course, now you know, catecholamines are directly acting sympathomimetic drugs because catecholamine have 3rd and 4th hydroxylation on benzene ring. So they bind with the receptor strongly and they produce their action well. We also use another word when drugs strongly bind with the receptor and strongly stimulate the receptor. What is the word used there? We say drug has high potency. Look, when drug binds strongly with the receptor, we say there's strong affinity. But when drug binds the receptor as well as stimulates the receptor, we say drug is a strong agonist. It means if drug is strongly binding with the receptor, that even in low doses it can produce high action. Even in low doses it can produce high action because even small amount will bind strongly. So we say drug has high potency. So what does it mean? All the catecholamines are highly potent drugs. Potent means as far as binding with the receptor, right? They have high potency. Now look, from all this discussion you can infer it. Look here, if we remove these hydroxylations, there is catechol. Let us suppose from here we remove these hydroxylations. This hydroxylation is removed and this hydroxylation is removed. Do you think now this compound will bind strongly to the receptor or weakly? So when it will lose its direct, so what will happen? When it will bind with the receptor weakly, then it will become high potency drug or low potency drug, right? Its affinity for the receptor will decrease, its activity on the receptor will decrease, and it will become low potency sympathomimetic drug, and it will be as a direct acting sympathomimetic drug it will fail. But there is something very good. When you knock off these two hydroxyls, drug become more lipid soluble. When you knock off these two hydroxyls, you remove them, drug become more lipid soluble. Am I right or wrong? Because hydroxyls are the negative charges, and by removing these hydroxyls, actually what you are doing? You are making the drug less polar and more lipid soluble. So such drug which is not having third and fourth hydroxylations, that can easily enter into nerve ending. Look here, you need to enter into nerve ending, it should be more lipid soluble. So such drugs which don't have third and fourth hydroxylation, they can enter into nerve ending and they can stimulate the release of norepinephrine from the nerve ending. They convert into indirectly acting sympathomimetic drugs. So again, compare this compound, this structure, right, and that structure. The primary difference is here third and fourth hydroxyls are present. In this structure, in this compound, third and fourth hydroxylations are absent. This structure is called, yes, catecholamine. And this structure is called, yes please, non-catecholamine. Non-catecholamine. Now, if someone asks you the difference in catecholamine and non-catecholamine, of course, first difference is the catecholamines are third, fourth dihydroxybenzene ring they are having. Non-catecholamine do not have catechol ring. They do not have third, fourth hydroxylation or benzene ring. So they are strongly binding with the receptors. So these are directly acting sympathomimetic drugs. So catecholamines are, yes please, you need to tell me, catecholamines are directly acting sympathomimetic drugs. I will write here, these are directly acting sympathomimetic drugs. And non-catecholamines are mainly, yes, they are indirectly acting, very good, indirectly acting sympathomimetic drugs. Is that right? No problem into this? Then another thing. You see, catecholamine have one more important thing. Because they are having hydroxyl group, catecholamines are highly polar compound. Catecholamines are highly polar compound. Now let's make a small, this is suppose your gastrointestinal system, right? Here is your liver, here is your general circulation, and here is your central nervous system. Let's talk some very fundamental things. Listen, if catecholamines are taken orally, actually catecholamines are never taken orally. Why? Let me tell you. When catecholamines are taken orally, come here, they are highly polar compound. Can they absorb well? No. And whatever little amount is absorbed, that will be destroyed by COMT and monoamine oxidase in the GIT mucosa, and also they will be destroyed by destructive enzymes in liver, monoamine oxidase, which is present in liver, and liver has some small amount of catechol O methyl transferase as well. Now listen, if you take catecholamines, right, if you take catecholamines orally, number one, they are highly polar compound, they will not be absorbed. Number two, whatever is absorbed will be destroyed by monoamine oxidases and catechol O methyl transferases, especially catechol O methyl transferase enzyme. You know where it attacks? This enzyme, COMT enzyme, this enzyme will attack this hydroxyl. What is this? COMT, catechol O methyl transferase, will remove a hydroxyl and add their methyl group. So that is why this enzyme is called catechol O methyl transferase, an enzyme which attack the catechol ring, remove the hydroxyl and add methyl group. Now, because this enzyme is abundantly present in our body, especially in GIT and liver, so what happens when catecholamines are taken orally? Number one, because they are highly polar, they are not absorbed well, and whatever is absorbed will be destroyed by these enzymes. So do you think significant amount of catecholamine will be reaching to the systemic circulation through oral route? No. So we say for catecholamine, oral bioavailability is very less. Oral, if you take the drug orally, catecholamines bioavailability is very less. That is why catecholamines are given parenterally. That is why that when you need to use catecholamines in a systemic fashion, you need to give a injection. Am I clear? Is that right? So catecholamines are given parenterally. Is that right? And they are not absorbed orally well, and their bioavailability is very less. Am I clear? Now imagine, compare it with non-catecholamine. Non-catecholamine, right, because they do not have these hydroxyls, so they are more polar or less polar? They are less charged or more charged? They are less charged, because non-catecholamines, let me tell you examples of non-catecholamines. Examples of non-catecholamines are classically like ephedrine and amphetamines. There are others also, amphetamines. Now, ephedrine and amphetamines, they do not have 3,4 hydroxylations. It means they are more polar or less polar? They are less polar. So they are more lipid soluble. So they can be taken orally. This is first thing. So write it here that these are given, catecholamines are given parenterally, and these are preferably given orally, because when non-catecholamines are taken orally, as they do not have these two hydroxyls, they will absorb better. And not only they will absorb better, there is one more thing. What is that? That, do you think this enzyme can attack non-catecholamine? No, because non-catecholamine do not have hydroxyl here. Non-catecholamine does not have catechol ring. And if non-catecholamine does not have catechol ring, how catechol O methyl transferase can attack the non-catecholamines? So because non-catecholamines cannot be attacked by catechol O methyl transferase, or non-catecholamines cannot be attacked by COMT, so duration of action of non-catecholamines will be prolonged. Duration of action of non-catecholamine is prolonged. So there is increased half-life, or there is increased duration of action by non-catecholamine. And of course, catecholamine has short duration of action, right? Catecholamines act in minutes, You know, catecholamine duration is counted in minutes, but non-catecholamine is acting over hours. Is that right? Now you understand, three things we have learned. You remove these two hydroxyls. Number one, you convert the direct acting drug into indirect acting first. This is catecholamine. When you remove these two hydroxyls, you convert catecholamine into non-catecholamine. And of course, when catecholamine is converted into non-catecholamine, then non-catecholamine are less polar, right? They bind with the receptor less, but they are taken up more in nerve ending and help in release of endogenous norepinephrine. So non-catecholamines are indirectly acting sympathomimetic drugs. Number two, they are less polar, they are better absorbed from GIT. Secondly, because they don't have catechol ring, so they are not acted upon by COMT. So they have longer duration of action and better bioavailability. So they can be used orally. Is that right? Then another thing. See, here is blood-brain barrier. There is blood-brain barrier. This is also a biological barrier made of lipids. Catecholamines are highly polar compound, right? Even though they are given parenterally, but can they go to central nervous system? No. When you give epinephrine or norepinephrine intravenously, they cannot cross the blood-brain barrier efficiently because catecholamines are highly polar compounds. Due to that reason, catecholamines, once they are administered parenterally, they do not have any direct action on sympathetic, they do not have any direct action in the central nervous system. But look at non-catecholamines. Non-catecholamines are not having hydroxyls. They are less polar. They can be absorbed from GIT. They can fool the COMT and go in high concentration there. But they have a problem. They cannot bind with the receptor strongly. But they can concentrate in nerve endings and release norepinephrine from there, indirectly acting. Plus, as non-catecholamines are more lipid soluble and less polar, they can cross blood-brain barrier. So they can go to central nervous system and they can produce, yes, effects and side effects in the central nervous system. That is why when we talk about amphetamines or ephedrines, which are non-catecholamines, they have very important actions and side effects in central nervous system. Is that clear? Let's have a break. So we were studying about structure and function relationship of the sympathomimetic drugs, and as we discussed that basic sympathomimetic parent compound is phenyl ring with ethyl and amine addition, right? So this is beta phenyl ethylamine, and previously we have discussed that if there are two hydroxylations at third and fourth, it's catechol compound, catecholamine. If these are not there, then they are considered non-catecholamines. And when we were applying this structure to the receptor, then what we were talking about, that catecholamines, due to the presence of these hydroxyls, bind strongly to the receptors. But non-catecholamines, because they do not have hydroxylation and third and the fourth carbon of the benzene ring, so they do not bind strongly with the receptors. They have low affinity for the receptor and they bind and bounce back. Due to that reason, they are not direct acting sympathomimetic drugs, they are indirectly acting sympathomimetic drug. Now we will come to another thing. Another characteristic of this molecule is that for a maximum direct sympathomimetic activity, the amino group and the benzene ring, amino group and the benzene ring, they should be separated by two carbons. Why? Because this area determines the primary binding of the drug, and this binding in this area determines the potency of the drug and affinity of binding, right? But this area, this part of the receptor, right, this determines intrinsic activity. This part determines intrinsic activity. To have a good intrinsic activity, it's very important that sympathomimetic drug should have its benzene ring and amino group separated by how many carbon atoms? 2 carbon atoms. So this is another important feature of structure and function relationship of sympathomimetic drugs. Now we come to very interesting phenomenon. What is that? You know, some of the sympathomimetic drugs bind with alpha 1 receptors, some of them bind more with beta 1, some of them bind with alpha 1, beta 1 and beta 2 receptors. How this happen? Why different sympathomimetic drugs stimulate different adrenergic receptor in a different fashion? Let's try to answer it. Let me draw different sympathomimetic receptor. Actually, this model receptor which I have made here, this is alpha 1 adrenergic receptor. What is this? Alpha 1 adrenergic receptor. Now I will draw the beta 1 adrenergic receptor and beta 2 adrenergic receptor, and you have to tell me where is the difference. You know, as kids find the difference in between the drawings. So I am going to draw beta 1 receptor here and beta 2 receptor there, and you are going to tell me where is the difference. It is beta 1 receptor. This is beta 1 adrenergic receptor. And now I am going to draw beta 2 adrenergic receptor. Yeah, this is beta 2 adrenergic receptor. Alpha 1 adrenergic receptor, beta 1 adrenergic receptors, beta 2 adrenergic receptor. Yes, where is the difference in them? The difference is in that points of the receptor where amino end binds. Alpha receptor has a small area where amino ends bind. Beta 1 receptor has larger area where, yes, amino end of the drug bind, and beta 2 receptor has very large area where what will bind? Amino end of the compound will bind. Now I will make, once you have appreciated this difference in the receptor structure, we will make a compound here. Look at this compound. Hydroxyl, so it is going to be catecholamine or non-catecholamine? It's going to be catecholamine. Okay, I will make it by, okay. What is this compound? Who will tell me the name of this compound? Yes. What is this compound? Okay. This is one compound. I will make another compound here. You compare the structure. Benzene ring, look, double hydroxylation, so it is also going to be catecholamine, CHOH, CH2 and only NH2. The difference in compound A, this is compound A and this is compound B. The difference in compound A and compound B is that it is having methylation on amino end, it does not have methylation, right? Okay, this compound is produced by converting this into catecholamine, hydroxylation here and adding methyl group here. Is that right? Every one of you knows the name of this compound and every one of you know the name of this compound. I'm not 99% sure, I'm 100% sure. Very good. The second one is, this B compound is epinephrine. Have you heard of it? And this is norepinephrine. The difference in epinephrine and norepinephrine is, epinephrine is methylated. You remember in previous lectures when we discussed that when norepinephrine is produced in the vesicle, then norepinephrine go to the cytoplasm. There is an enzyme called methyl transferase. We transfer a methyl group to norepinephrine amino end, and compound convert from norepinephrine to epinephrine. You know what is the easiest way to remember epinephrine? Epinephrine is methylated norepinephrine. Epinephrine is methylated norepinephrine. That's so simple. Is that right? Now listen carefully. This is our balanced compound, right? Epinephrine, look here. Attention please. This is its amino end. Epinephrine, look here, attention. This point, this end of the epinephrine can fit here. It can also fit here. It can also fit there. You are understanding? Because epinephrine amino end is methylated amino end, right? And it can fit into alpha 1 receptor. It can, yes, fit into alpha 1 adrenergic receptor, and this amino end can fit into, yes, beta 1 adrenergic receptor, as well as this end can fit into, yes, beta 2 adrenergic receptor, even though it fit into this part and remaining is empty. But epinephrine can bind with alpha 1 adrenergic receptor, as well as it can bind with beta 1 adrenergic receptor, as well as epinephrine can bind with the beta 2 adrenergic receptor. Is that right? Due to this reason, epinephrine has which actions? Epinephrine has alpha 1 actions and also beta 1 action and also beta 2 action. We can say epinephrine is a balanced sympathomimetic drug. This term I'm telling you, made myself. That's a balanced drug. Balanced in a way, it works on all adrenergic receptor with the almost same affinity. Am I clear? There's no problem, right? Now you imagine, look, attention please. From this epinephrine, you remove methyl group. You remove methyl group, what is the result? Norepinephrine. Now norepinephrine can fit with alpha 1 receptor. You know, this point can fit into alpha 1 receptor, can also fit and stimulate beta 1 receptor, but to have stimulation on the beta 2 receptor, you need relatively heavy. So you have knocked out this. When you remove this methyl, right, actually this drug loses its action on the beta 2 receptor. Listen, the principle is this. Attention please. Look at these points. Amino end, more heavy, amino end, more it become heavier, beta 1 and beta 2 action become increased. And amino end, you make it lighter, it will have more alpha 1 action. We can make it like this. This is the balanced epinephrine. Is that right? If you are making amino end of the drug lighter, action will move to this side. And if you are making amino end heavier, actions will move in that direction. It's so simple. So, norepinephrine has ability to stimulate alpha 1 adrenergic receptor, has ability to stimulate beta 1 adrenergic receptor, but does not significantly stimulate beta 2 receptors. So, what are the actions of norepinephrine? Alpha 1 actions, beta 1 actions, and very little beta 2. It's so simple. If next time someone asks, tell the physiological and pharmacological actions and the difference of these actions between epinephrine and norepinephrine, it's so simple. When you tell about the pharmacological actions of epinephrine, tell all the alpha 1 adrenergic actions in the body, all the beta 1 adrenergic actions in the body. For example, alpha 1 action like vasoconstriction, all beta 1 action. For example, one of them is cardiostimulation. beta 2 action like bronchodilation. But when you go to norepinephrine, it has alpha 1 action like most of the vasoconstriction. It has beta 1 action, it is cardiostimulation, but it is not bronchodilator. Is that right? It is not relaxing the uterus, which is beta 2 action. It is not releasing glucose from the liver, glycogenolysis, which is beta 2 action. Am I clear? Now it's so simple. Now let's produce another compound in which we make amino end heavier. Right? Hydroxyl, and CHOH, CH and air I put. Now NH, CH2, NH, CH, okay, CH3 and CH3. Now what we have done, here now we have changed the amino end. Amino end has, what are these? Has become heavier. Because it has become heavier, it is so heavy it cannot fit into alpha 1 well, but it will fit very well into beta 1 and beta 2 receptors. So naturally, intuitively, you can tell me that this drug will have very little alpha 1 action but heavy beta 1 action and heavy beta 2 action. Is that right? And can you tell me the name of this drug? Isoproterenol. What is the name of this drug? Isoproterenol. Am I clear? No problem? So what happens in isoproterenol? That at the amino end there is substitution with heavy alkyl group, and due to this reason, because amino end is very heavy, so it loses alpha 1 action but it keeps the beta 1 and beta 2 action. Am I clear? No problem. Now I will make one more. Right. This is of course catecholamine, CHOH, CH2, and now we'll put amino group here, NHC, CH3, CH3, CH3. So it becomes even more heavier. Amino end has become really very heavy. It is so heavy that it will bind with beta 1 weakly, because beta 1 cannot accommodate, alpha 1 cannot accommodate such a heavy amino substitution at all. Beta 1 bind it very little and beta 2 action remain very strong. So now this drug with very heavy amino substitution, it has very little beta 1 action, but real action is beta 2. Is that right? What is the name of the drug? You know it. Terbutaline. Very good. Salbutamol. All these terbutaline, salbutamol, albuterol, all those drugs which are strong beta 2 stimulant have very heavy amino groups. Is that right? So I should write the drug name here. Terbutaline. You know, it is having a strong beta 2 actions, and because it has strong beta 2 stimulatory action, of course it is very commonly used as bronchodilator in patients with asthma. What is the advantage? You play with the molecules and you get advantages or disadvantages. What we have played, look here, this primary structure was come here. You have norepinephrine, is that right? Or you have epinephrine. What did you do there? You made this end very, very heavy, so it lost alpha 1 action. When you want a patient, you have a patient with bronchospasticity or patient with asthma, you want to do bronchodilation, but you don't want alpha 1 action. You don't want beta 1 action. So to remove the alpha 1 action and beta 1 action, you simply make this end very, very heavy. So alpha 1 side effects are lost. Even beta 1 unwanted actions are less. But when you give this drug in very high concentration, then it's also start binding significantly to beta 1 and beta 1 side effects will start appearing. That is why these salbutamol, terbutaline, albuterol, these drugs in higher concentration start cardiostimulation. Otherwise, in low concentration, they are good bronchodilator with some other beta 2 action like tremors or beta 2 action on the liver and producing high glucose release from the liver by glycogenolysis. Is that right? No problem into this? So this is how you understand now that differences between norepinephrine, epinephrine, isoproterenol and terbutaline. What we have learned up to now is that as you are making amino acid end heavier, you are losing the alpha 1 action and getting more beta actions. And if you make it very heavy, even beta 1 action is lost and strong action is on beta 2. But as you keep on making amino end lighter, beta actions are reducing and alpha 1 actions are more. Right? Let's have a break. Now, let's play some tricks. And you know, these are norepinephrine, epinephrine, isoproterenol and terbutaline, all of them are catecholamine. Let's alter their structure and get some non-catecholamines. For example, first we alter the structure of epinephrine, right? And how we alter the structure of epinephrine? First I draw the epinephrine and then we produce some alteration in epinephrine structure to get some non-catecholamine. Now this is, of course, your, what is this? What is this compound? This is epinephrine. And now what we do with epinephrine, that just knock off these two hydroxyls, remove these two hydroxyls. Is that right? From norepinephrine, you remove these two hydroxyls and plus you add a methyl group here. Remove these two hydroxyls and add a methyl group here. Now we see this is a different compound and it will have different pharmacodynamics and different pharmacokinetic property, right? Number one, step by step we'll move. When we remove these two hydroxyls, the drug becomes less polar and more lipid soluble. So it means this drug can cross GIT barrier, it can be absorbed from the GIT, it can also cross blood-brain barrier, right? This is one thing. Secondly, first of all, what is the name of this compound? This compound is ephedrine. This compound is ephedrine, right? Now, when you remove these two hydroxyl, it becomes more lipid soluble, it can absorb from GIT, it can cross blood-brain barrier, it can act in central nervous system. Secondly, when you are removing these hydroxyls, it is no more catechol ring. Because it is no more catechol ring, then this enzyme, you know what is this enzyme? Catecholomethyl transferase. This attacks this component of the catechol ring. But because we have removed the hydroxyls and it is not catecholamine, it does not have catechol ring, so catecholomethyl transferase cannot attack this compound. So this compound will not be destroyed in GIT or in the liver. So duration of action of the drug will become more and oral bioavailability of the drug will also become more. So it can be better absorbed orally because it is not destroyed by COMT in the GIT or liver. So oral bioavailability is more. Secondly, because these two hydroxyls are not there, so drug does not bind properly with adrenergic receptors. So it does not have direct sympathomimetic action. It has very little direct sympathomimetic action, but it has, because it is non-catecholamine, it can have more indirect sympathomimetic action. So we can say ephedrine is non-catecholamine which can absorb well orally, right? Which can cross the blood-brain barrier and act in central nervous system, right? And it is indirectly acting sympathomimetic drug. Another thing, because we added a methyl group here, by addition of methyl group, we make this compound more lipid soluble. And when we make this compound more lipid soluble, again that help an absorption from GIT and help in crossing the blood-brain barrier and having more action in the central nervous system. Is that right? Another thing, as you know, this is the enzyme monoamine oxidase. Monoamine oxidase enzyme is sitting on the alpha carbon, and then what it is doing? It is oxidizing the beta carbon hydroxyl. Now what we do when we put methylation here, this enzyme cannot bind with the compound because this enzyme monoamine oxidase binds here. Because monoamine oxidase cannot bind there, its mouth is closed. This is monoamine oxidase weeping. Why? Because it cannot bind here well and cannot attack here. So monoamine oxidase failed to destroy ephedrine. So it means that when ephedrine is taken up into adrenergic nerve endings, then within the adrenergic nerve endings, monoamine oxidase cannot destroy this drug efficiently, so it will stay in the nerve ending for a longer duration and it will produce indirect sympathomimetic action for longer duration. Is that right? Any question up to this? There's no question. Now we play another trick. Let's modify norepinephrine and convert into another non-catecholamine. Now this was your amphetamine. Now we are going to make another compound. This is also non-catecholamine. This compound is also non-catecholamine. What we do, this is its benzene ring. We have removed these two hydroxyls. These two hydroxyls here we have removed. So it means we convert the catechol compound into non-catechol compound. Please correct, in ephedrine we have removed this hydroxyl. In ephedrine, no, it is there. It is okay. Now we have to come to the new compound. What we have done, that we have taken the norepinephrine, removed third and fourth hydroxylation, plus we have also removed, another hydroxylation from this point. So there are 3 hydroxyls have been removed. Again, you took the norepinephrine, remove the third and fourth hydroxyls, and also remove the hydroxyl from beta carbon. Is that right? When so many hydroxyls are removed, it becomes highly lipid soluble. Is that right? Very good oral absorption and very good crossing from blood-brain barrier. Is that right? And of course, it is not directly acting sympathomimetic drug. It is indirectly acting sympathomimetic drug. And because this hydroxyl is not there, can monoamine oxidase attack here? It is just like this. Someone does not have ear. Can you remove his ear? No. So monoamine oxidase cannot attack here. COMT cannot attack here. So drug absorption from GIT and bioavailability from GIT become very good, and destruction of the drug by COMT and monoamine oxidase is far less. Due to that reason, this drug has a long duration of action. And remaining thing is the same, that CH. As we added methyl here, we will also add methyl there. Is that right? We have also added the methyl there. And what is the last thing there? Yes? NH2. And what is the name of this drug now? Yes, who will tell me the name of this drug? This is non-catecholamine. This is amphetamine. So this was two examples in which I have shown you the structural and functional difference between catecholamines and non-catecholamine. Now, do you have any question? Do you have any question? No questions. Now I will rapidly review something, right? You will tell me. If these two hydroxyls are present in the structure with the benzene ring, it is catecholamine or non-catecholamine? It is catecholamine. Catecholamine have strong direct acting action or non-catecholamine have strong direct acting action? Catecholamine. Okay. In non-catecholamines, because these hydroxyls are not there, they will be more lipid soluble or less lipid soluble? Okay, now I will ask in another way. Right, you have to tell me drug is catecholamine or non-catecholamine. There is sympathomimetic drug which is well absorbed from the GIT and going to central nervous system. It is catecholamine, non-catecholamine? Non-catecholamine. There is sympathomimetic drug. It has to be given parenterally and short duration of action. Catecholamine. There is sympathomimetic drug which can absorb orally, have long duration of action and go to the central nervous system. Yes, non-catecholamine. Okay. There is a drug which is catecholamine, I am telling you, which is catecholamine. It has very, very heavy amino substitution. It is strongly alpha 1 action or strong beta 2 action. Beta 2 action. There is another drug, an amino end is very light. It has strong alpha 1 stimulation or it is strong beta 2 stimulation. Strong alpha 1 stimulation. Now I will tell the drug and you will tell me the name. Okay, I will tell the action and you will tell me the name of the drug. The profile of the drug is, there is a sympathomimetic catecholamine which has equal alpha 1 action, beta 1 action and beta 2 action. What is the drug? Epinephrine. Very good. It is epinephrine. There is another drug. It has a strong alpha 1 and beta 1 action, but beta 2 is very less. This is norepinephrine. Very good. There is another drug in which beta 1 and beta 2 actions are very well, but there is very little alpha 1 action. Isoproterenol. Very good. And if I say there is a drug which has very little beta 1 action but strong beta 2 action, what is that? Terbutaline. That's great. Class dismiss. Thank you.